Hello guys, welcome you all on Unacademy, India's largest learning platform. First of all, a little bit of introduction. Myself, Dr. Nidhi, I am your physiology educator at Unacademy. This is our Telegram page. You can follow us out here. This is my page on Unacademy. I have taken many plus classes, many special classes, so anytime you can join. This is my page. My page is unacademy.com/KGMC. You can follow me out there so that you will get notification of every classes. This is the code Dr. Nidhi. If you want to join any paid course, you can use this referral code, that is Dr. Nidhi, to get additional 10% off. Moving further, this is the free test calendar week 5 for the April, and we are left with two tests, that is today at 7 p.m. and 10 p.m. So moving further, we are going to have this all India mock test for the NEET PG 2022. Those who are giving the examination this year only, that is NEET PG 2022, do give this mock test. This mock test is going to give you all India rank prediction. This mock test is going to happen on 1st May 9 a.m. Do remember the date and timing. For that, first of all, you have to enroll yourself for the test. For enrollment, you have to use the code, that is Dr. Nidhi. By using this code, you will unlock your free live test, and do give this test because this test is going to give you all India rank predictions. Moving further, we are started with this Unacademy goal where you can get 20% off on all the subscription. You have to if you have to take the subscription, do use the code, that is Dr. Nidhi. After using the code, you will get 20% additional discount in your subscription. Moving further, this is the fee structure. This is the fee structure for the plus subscription. This is the fee structure for iconic subscription. This is the fee structure for light subscription. Light subscription is newly added one where you get access of all the test series related to the NEET PG examination, and it is very economical also. 2-month subscription fee is 1,920 only. 3-month fee is 2,400 only. 6-month fee is 4,320 only. 9-month fee is 4,800 only, and 1-year fee is 5,280 only. Now we are started with this MBBS first year batch also, and its fee is somewhat like this. 3-month fee is 4,400 only. 6-month fee is 8,000, and 1-year fee is 9,600 only. So as per your requirement, you can take subscription and start your preparation. This is the batch we are started with, that is MBBS first prof batch. That is started from the 25th April. Okay, fine. And this is the fee structure. This is the price, that is including the 20% off. 3-month fee is 4,400 only. 6-month fee is 8,000, and 1-year fee is 9,600 only. Do enroll yourself, everybody. If you are in your first prop, you can join this batch, that is MBBS first prop batch. We are started with this Unacademy light subscription, where you get access of all the test series like subject wise test, system wise test, full length mock test paper, previous year question paper, test series curated by the top educator. You also get access for all the grand tests related to the NEET PG, INSET or the FMG examination. Moving further, we are having this 2 type of subscription, plus subscription and iconic subscription. First, coming to the benefit of all this plus subscription, you will be able to access both the live and recorded session. You get an opportunity to learn from India's top educator for the medical examination. We always conduct this live tests and live quizzes. From that, you can analyze your preparation at any point of time. You have a flexibility. You can study on the device of your choice. We have a question bank which consists of 25,000 plus question. These are high yield question, clinical based question, and this is with the explanation. So this is going to be very beneficial for all of you. Moving further, the iconic subscription, where you get access of India's 2 best platform, that is Unacademy and the Prep Ladder. So you are going to get all the plus benefit. Like I said, live classes, recorded classes, question bank, live tests, live quizzes. Along with that, you get access for the Prep Ladder. In this, you can access the clinical and integrated essential of Prep Ladder, video lecture from the Dream Team, Question Bank 3.0, rapid revision and snapshot, and you will also be provided with the treasure and dream notes. So if you want to access this prep ladder also, go for the iconic subscription, everybody. Moving further, we are started with this the NEET PG previous year question bank, where all the 4-year paper are included for the NEET PG, INSET and FMG. This is going to give you the quick revision before the actual examination. Enhanced solution explanation is also there for better understanding of the concept. 2800 previous year questions for your practice. So you have to, what you have to do, so you have to upload the app, that is Unacademy app, and go to the self study and the practice paper, and you will select the subject and start your revision. So moving further, we are started with this auto daily practice paper. This is for the plus student, where you get 5 to 10 MCQ after every live classes. These questions are hand-picked by your educator, and that is related to the topic which you studied in the session, and that's why it is going to help you to understand the concept way more better. So we are started with this batch also, batch on frequently forgotten volatile topic and emergency medicine. This is going to be start on 4th May, and its duration is 10 days only. So if you are preparing for the examination, you must join this batch, which is going to have a frequently forgotten volatile topic and the emergency medicines. So you can join this one if you are targeting this year examination only. So moving further, we are going to start the topic. Today we are going to have the marathon session, in which we are going to revise the respiratory system. So let's start the topic. Coming to the revision, today we are going to revise the respiratory system. First topic which we are going to revise is structural component of lung. So to understand this structural component of lung, we have to first understand this generation of lung airway. This is defined by Weibel's. So this model is important, Weibel's model. According to this model, our airway is divided into 23 generation. इसमें जो first 16 generation है, that is conducting airway or dead space. ठीक है, last 7 generation क्या है? Last 7 generation is exchange airway, alveolar airway or respiratory airway. Why the first 16 generation is known as dead space? Because this is not involved in gaseous exchange. So that's why it is only the conducting pathway. So that's why it is known as conducting airway or dead space. Last 7 generation में क्या होता है? Gaseous exchange occurs. So that's why it is known as exchange airway, alveolar airway or respiratory airway. This is the diagram. This conducting airway starts from trachea and it ends with the terminal bronchiole. And this respiratory airway starts from this respiratory bronchioles and it ends with the alveolar sac. So you can say this trachea is the largest one and alveolar sac is the smallest one, and the terminal bronchiole mark the transition between these two, conducting airway and respiratory airway. So all these points are very important. हमारा first 16 generation क्या है? Conducting airway, it starts from trachea, it ends with the terminal bronchiole. Last 7 generation क्या है? Respiratory airway, that start with the respiratory bronchiole and end with the alveolar sac. So now coming to the first, that is conducting airway. इसको अब हम डिटेल में देखेंगे. This conducting airway की epithelium की अगर बात करें, so its epithelium is pseudostratified ciliated columnar epithelium. Pseudostratified ciliated columnar epithelium, and it consists of 2 stem cells, that is basal cell and clara cell. So these 2 cells are important to remember. Epithelium कैसा है? Pseudostratified ciliated columnar epithelium. So the cilia is important. So see, this is the diagram. कैसा epithelium है? Pseudostratified. Cilia present है, ciliated, column like cells है, columnar epithelium cells. 2 हमारा stem cell out here are basal cell and the clara cell. They both act like a stem cell. Is this clear with everybody? Moving further to the cilia. What is the cilia? Cilia are the finger-like projection on the lining cell, and they are capable of movement. Why the cilia is capable of movement? Because of presence of protein that is called as dynein. Due to presence of this dynein, हमारा cilia कैसा होता है? Motile होता है. So what is the function of this cilia? Ciliary movement की वजह से क्या होता है? हमारा जो sputum है वो nasopharynx से expelled होता है. So this is the function. Now coming to the metachronism. What is the metachronism? हमारा जो cilia है एक synchronized way में सारी cilia move करती है, and that phenomena is known as metachronism. और this cilia. अब बात करेंगे next function of the cilia. First function is expulsion of sputum. Second function is during embryological development, the cilia is responsible for rotation of internal organ. Means our internal organ is basically different position पे होता है initially, but after this ciliary movement क्या होगा? हमारा cilia की movement की वजह से our internal organ excuse me, our ciliary movement causes rotation of this internal organ, and internal organ अपने actual position में आता है. So this dynein is important for the ciliary movement. Beside that, it is also important for movement of sperm as well as fallopian tubule. Now coming to the clinical aspect, that is absence of this dynein. So absence of dynein हो जाएगा तो क्या होगा? Ciliary movement is stop, sperm movement नहीं होगा, fallopian tube movement नहीं होगा. So it is going to lead the immotile cilia syndrome. And out of this, the most important one is this Carter-Genus syndrome. This consists of a triad. कौन कौन से triad होते हैं? Sinusitis, bronchitis, and the situs invertus or sinus invertus. ठीक है, क्या क्या ट्राइड मिलेंगे? डू रिमेम्बर साइनोसाइटिस बिकॉज स्पुटम इज नॉट क्लियर. ठीक है, अगर अगर साइनोसाइटिस को अगर ट्रीट नहीं करते हैं तो इट कैन लीड टू द ब्रोंकिटाइटिस. ठीक है, एंड इंटरनल ऑर्गन डिफेक्टिव रोटेशन हो सकता है, तो दैट इज नोन एज साइटस इनवर्टस. ठीक है, प्लस इमोटाइल सीलिया सिंड्रोम, कार्टर-जेनस सिंड्रोम में ट्राइड के साथ साथ हमें क्या मिलेगा? Associated infertility will also be seen because dynein absent है. Dynein absent है तो sperm movement भी नहीं है और fallopian tubule movement भी नहीं है. So both male and female दोनों ही में हमें क्या मिलेगा? Infertility will be seen. In male, the immotile sperm will be seen, and that is known as asthenospermia. Immotile sperm due to absence of this dynein is known as asthenospermia. Is this clear with everybody? So this is about the Carter-Genus syndrome. Do reply first. Is this clear? So moving further to the next disorder related to our cilia is cystic fibrosis. क्या सिचुएशन है? यहाँ पे cilia is normal, dynein is present, but cilia cannot propel this sputum because out here the sputum are thick. Why the sputum are thick? Because out here we have this cystic fibrosis transmembrane regulator gene defect, CFTR gene defect. Cystic fibrosis transmembrane regulator gene defect की वजह से क्या होगा? Sputum is thick and that is going to cause this cystic fibrosis. So what we are going to see in this situation, this cystic fibrosis transmembrane regulator gene क्या करता है? It mediate the opening of chloride channel. Chloride mix with the sputum and normally sputum are thin. But due to mutation of this gene, what happened? There will be defective chloride opening, and that's why that is leading to the thick sputum. So that's why अगर treatment line पे अगर हम जाते हैं तो we will give this calcium channel opener. ठीक है, सॉरी क्लोराइड चैनल ओपनर, ताकि क्लोराइड आयन हमारा इन्फ्लक्स स्टार्ट हो जाए, एंड दैट इज गोइंग टू मिक्स विद द स्पुटम एंड दैट इज गोइंग टू कॉज thinning of sputum. So we use this EVA catheter in the cystic fibrosis. Is this clear? सिस्टिक फाइब्रोसिस क्यों है? सिस्टिक फाइब्रोसिस ट्रांस मेम्ब्रेन रेगुलेटर जीन डिफेक्ट की वजह से. एंड व्हाट डज दिस सिस्टिक फाइब्रोसिस ट्रांस मेम्ब्रेन रेगुलेटर जीन डू? इट कॉजेस ओपनिंग ऑफ दिस क्लोराइड चैनल, क्लोराइड efflux start, and that chloride mix with the sputum, and that causes thinning of sputum. Is this clear? Moving further to the next unique feature of our conducting airway is presence of smooth muscle lining in our conducting airway. And this smooth muscle lining is maximum in terminal bronchioles. Do you remember this point is important? So moving further, what happened during normal condition? क्या होगा अगर due to exposure of cold and dust, this conducting airway smooth muscle undergo contraction, and that is going to lead bronchoconstriction. जिसकी वजह से क्या होगा? Air flow decrease होगा, air flow resistance is going to increase. But in exaggerated conditions क्या होगा? अगर bronchoconstriction is more in our conducting airway, that is going to lead the bronchial asthma. So इसलिए हम इस situation में we give the treatment by bronchodilators. ठीक है? Is this clear? So agent अब बात कर लेते हैं. Now coming to the agent that causes this bronchoconstriction are our parasympathetic nervous system activation. That activation is going to lead formation of acetylcholine, and so this acetylcholine is going to cause the bronchoconstriction. So that's why when we give, now coming to the treatment line, acetylcholine blocker like ipratropium bromide, they are going to cause relaxation, they are inhibiting the constriction of bronchioles. So that's why it is used in the treatment of asthma. Acetylcholine blocker like ipratropium bromide is used in the treatment of asthma. Synthetic अगर acetylcholine की बात करेंगे like methacholine, तो most common side effect यहाँ पे क्या मिलेगा हमें? Bronchoconstriction, because it is going to act like acetylcholine, and acetylcholine क्या करेगा? Acetylcholine is going to cause bronchoconstriction. Is this clear? Next is the histamine. This histamine also causes this bronchoconstriction. Leukotriene. This leukotriene is also going to cause the bronchoconstriction, and this leukotriene is the most potent bronchoconstriction. So that's why the leukotriene blockers like montelukast are very effective in treatment of bronchial asthma. Is this clear, everybody? So agents that causes bronchoconstriction are our parasympathetic nervous system, our vagal stimulation, our acetylcholine, our our leukotrienes, our histamine, they all causes bronchoconstriction. Now coming to the agent that causes bronchodilation. In this we have the sympathetic nervous system that act via beta 2 receptor to cause this bronchodilation. So that's why beta 2 agonists like salbutamol, it is going to cause bronchodilation. So that's why it is used in the treatment of asthma. Next is the nitric oxide. It is a universal dilator. So out here also it is going to dilate our bronchioles. Next is the vasoactive intestinal peptide. This is also going to cause the bronchodilation. Now after the conducting airway, moving to the alveolar airway. Our alveolar airway is also known as exchange airway because यहीं पे हमारा gaseous exchange होता है. And it is also known as respiratory airway. इसमें जो हमारा आता है वीवल मॉडल की अगर बात करें तो लास्ट 7 जनरेशन ऑफ वीवल मॉडल कॉरस्पॉन्ड्स टू आवर alveolar airway, and this alveolar airway is responsible for gaseous exchange, already discussed. So that's why it is known as exchange airway. So this alveolar airway consists of two type of pneumocyte, type 1 and type 2 pneumocyte. This type 2 pneumocyte is responsible for production of surfactant. So this point is important from the exam point of view. Which type of pneumocyte is going to form the surfactant? Type 2 pneumocyte. And this type 2 pneumocyte also acts as a stem cell for alveolar airway. Conducting airway के लिए कौन-कौन से हमारे stem cells होते हैं? Anybody? Conducting airway में we have which type of stem cells? Do reply fast. Stem cell in a conducting airway. Basal cell and Clara cell are the stem cell in our conducting airway, while in our alveolar airway we have this type 2 pneumocyte acting like a stem cell. So this is the diagram. This is the type 1 pneumocyte. This is the type 2 pneumocyte. Type 1 pneumocyte is 95% of alveolar surface is covered by this type 1 pneumocyte. They are squamous, they are extremely thin. They are involved in gaseous exchange. While type 2 pneumocyte is roughly cuboidal and it is granular in nature and covers only 5% of alveolar surface, and they are going to secrete this pulmonary surfactant. Take clear? Moving further to the surfactant structure, first coming to the structure part. This surfactant consists of lipid and the protein molecule. Lipid, in this we have major lipid and the minor lipid. Major lipid is lecithin, dipalmitoyl phosphatidylcholine. Do remember this name because काफी बार एग्जाम में आता है. The major lipid in our surfactant is lecithin, or you can say dipalmitoyl phosphatidylcholine is the major lipid in our surfactant, and the minor lipid in our surfactant is sphingomyelin. And protein की बात करेंगे. Protein in our lipid is known as surfactant protein, and we have 4 type of surfactant protein. Surfactant protein A, B, C and D. Among this, A and D, surfactant protein A and T is responsible for lung immunity. Is this clear with everybody? So moving further, what is the significance of this lipid? Lecithin upon sphingomyelin ratio more than or equal to 1 equal to 2 is signifying this adequate fetal lung maturity. ठीक है? And when amniotic fluid is taken in a test tube and it is shaken, so if bubble appear, then it is indication of the presence of surfactant lipid. ठीक है? This test is known as shake test, bubble test or Clement test, and this is showing our adequate fetal lung maturity. So for checking this adequate fetal lung maturity, we can do one first thing, that is lecithin upon a sphingomyelin ratio. Second thing which we can do is shake test, bubble test or Clement test. Is this clear with everyone? Moving further to the surfactant production appearance. Surfactant production starts at 28 to 32 week of gestational period. And now coming to the most important part, that is what is the function of the surfactant. Normally the alveolar surface is lined up with the water molecule. Suppose this is our alveoli. This alveoli in a normal situation is lined up with the water molecule, and this water molecule exert the surface tension towards the center, and due to that क्या होगा, हमारा lung has tendency to collapse. So this has tendency to collapse the alveoli. So due to that क्या होगा, हमारा surfactant क्या करता है, water molecule को break करता है, and that is going to decrease the surface tension. ठीक है, तो क्या क्या function हो गया, surface tension decrease करता है, it prevent the collapse of alveoli. So it is going to ensure the stability of alveoli. Is this clear with everybody? Now Laplace law क्या कहता है? Tension is equal to pressure into radius. Alveoli कैसा है? Sphere है. So out here twice the tension is equal to pressure into radius. So what does surfactant do? Surfactant हमारा surface tension को reduce करता है. And tension reduce होगा. See. तो radius क्या हो जाएगा? Increase. Because tension is equal to pressure into radius. So tension is directly proportional to the radius. So tension, surface tension reduce होगा. Sorry. So radius is going to increase. It is going to surface tension reduce होगा. हमारा जो pressure होगा वो increase होगा. So that's why radius of alveoli is going to increase. So surface area is going to increase. So the collapsing pressure decreases. Is this clear with everybody? अब हम बात करेंगे surfactant are stored in type 2 pneumocide in the form of lamellar bodies. So do remember this point. Storage किस form में होता है? Storage होता है हमारा lamellar body के form में, and that's why lamellar body count is important because इससे हम test कर सकते हैं fetal lung maturity. So clear हुआ? Fetal lung maturity के लिए we can do first thing, that is less than upon a sphingomyelin ratio greater than or equal to 2. Second thing we can do is bubble test, Clement test. Third thing which we can do is lamellar body count. Is this clear? Moving to the further to the regulation of surfactant production. So there are some factors that is going to increase the surfactant production. There are some factors that is going to decrease the surfactant production. First, coming to the factor that increases surfactants are. First is steroids. Our glucocorticoids, यानी our cortisol is going to increase the surfactant production. So that's why in preterms baby में क्या होगा? Immature lungs होंगे, and that's why in preterm baby we give this dexamethasone and betamethasone to increase the surfactant production in the baby. ठीक है? Next is the thyroid hormone. Thyroid hormone T3 and T4 also increases the surfactant production. Next, the factor that decreases surfactant are always and always pathology. ठीक है? कैसे pathological है? Because अगर gestational diabetes mellitus mother positive आई तो उस केस में इन्फेंट में क्या होगा? सर्फेक्टेंट का प्रोडक्शन डिक्रीज हो जाता है एंड दैट इज गोइंग टू लीड दिस हाइलीन मेम्ब्रेन डिजीज. एंड हाइलीन मेम्ब्रेन डिजीज यानी ये कैसा हो गया? पैथोलॉजिकल कंडीशन हो गया. तो सर्फेक्टेंट का प्रोडक्शन हमेशा पैथोलॉजिकली डिक्रीज होता है. नॉर्मल सिचुएशन में ये डिक्रीज नहीं हो सकता. इज दिस क्लियर? नाउ अगर हाइलीन मेम्ब्रेन डिजीज है इन्फेंट में तो ट्रीटमेंट की अगर बात करेंगे तो वी गिव दिस ड्रग फॉर्म ऑफ सर्फेक्टेंट लाइक लुसिनैक्टिन एंड बेरैक्टिन. क्लियर हुआ एवरीवन? सो फैक्टर दैट इंक्रीजेस सर्फेक्टेंट आर, कौन से फैक्टर हमारे सर्फेक्टेंट प्रोडक्शन को इंक्रीज करता है? आवर कॉर्टिसोल, our dexamethasone, betamethasone is going to increase the cortisol production. Our thyroid hormone T3 and T4 is going to increase the surfactant production. Factor that decreases surfactant is always and always pathological. Gestational diabetic mellitus अगर मदर है तो इन्फेंट में क्या होगा? हाइलीन मेम्ब्रेन डिजीज होने के काफी हाई चांस होते हैं. एंड इन दैट सिचुएशन वी गिव द ड्रग फॉर्म ऑफ सर्फेक्टेंट लाइक लुसिनैक्टिन और बेरैक्टिन. Moving further to the mechanism of breathing. To understand that, first of all, coming to the Boyle's law, what does Boyle's law state? It states that pressure is inversely proportional to the volume. If volume increases, pressure is going to decrease. अब हम आ जाते हैं अपने respiratory physiology पे. तो volume out here is, we are talking about the tidal volume of 500 ml. And pressure की अगर बात करेंगे तो we are talking out here for the 3 pressure, that is intrapleural pressure, alveolar pressure और transpulmonary pressure. So 3 pressure के बारे में हम डिस्कस करेंगे, intrapleural pressure, alveolar pressure और transpulmonary pressure. First coming to the intrapleural pressure. As the name suggests, intrapleural means between the two pleural layers, the pressure between the two pleural is going to cause us intrapleural pressure. ठीक है, तो रेस्टिंग कंडीशन में इंट्राप्ल्यूरल प्रेशर नेगेटिव होता है. व्हाई इज इट नेगेटिव? बिकॉज प्ल्यूरा क्या है? प्ल्यूरा हमारा एक साइड से लंग से अटैच है एंड एक साइड से चेस्ट वॉल से अटैच है. ठीक है, चेस्ट वॉल की टेंडेंसी है टू मूव आउटवर्ड, लंग की टेंडेंसी है टू कोलैप्स. So between these two opposite forces क्या होगा? प्ल्यूरा stretched होगा and due to stretching क्या होगा? हमारा जो vacuum like state between the two pleural layer will be created and that's why intrapleural pressure कैसा होता है? It is always and always negative. So see, this is the diagram. Let me change the color. ये हमारा लंग हो गई, ये हमारा लंग वॉल हो गया, ये हमारा चेस्ट वॉल हो गया एंड बिटवीन दीज टू वी हैव दिस प्लूरल स्पेस जहाँ पे क्या है? वैक्यूम लाइक स्टेट क्रिएट होगा एंड दैट इज गोइंग टू कॉज दिस इंट्राप्लूरल प्रेशर नेगेटिव. सो व्हाट हैपन ड्यूरिंग इंस्पिरेशन? अगर बात करेंगे तो ड्यूरिंग एन इंस्पिरेशन वॉल्यूम ऑफ द लंग इज गोइंग टू इंक्रीज एंड वॉल्यूम इंक्रीज होगा तो फ्रॉम द बॉयल्स लॉ volume is in pressure is inversely proportional to the volume. Volume is increasing, so pressure is going to decrease. So intrapleural pressure from minus 2.5 decreases to minus 6 mm of Hg. Means हमारा intrapleural pressure क्या हो गया? It become more negative during inspiration. अगर expiration की बात करते हैं तो during expiration क्या होगा? Volume of lung is going to decrease. So intrapleural pressure क्या होगा? Increase. So it increases from minus 6 to minus 2.5 mm of Hg. Is this clear everybody? Intrapleural pressure कैसे change हो रहा है? Resting condition में it is negative, it is minus 2.5 mm of Hg. Inspiration में volume increase होगा, pressure is again going to decrease and from minus 2.5 ये decrease होके minus 6 mm of Hg पे reach कर जाएगा. During expiration क्या होगा? Volume in the lung it is going to decrease and intrapleural pressure increase होगा and that's why from minus 6 से ये reach होता है minus 2.5 mm of Hg. Is this clear everyone? Everybody, moving further. Now coming to the alveolar pressure. रेस्टिंग कंडीशन में alveolar pressure is 0. इंस्पिरेशन में अगेन क्या होगा? वॉल्यूम इंक्रीज होगा, सो प्रेशर इज गोइंग टू डिक्रीज फ्रॉम 0 इट रीचेस टू minus 1 mm of Hg. ठीक है, एट द एंड ऑफ इंस्पिरेशन alveolar pressure अगेन बिकम 0. अब एक्सपिरेशन स्टार्ट होगा तो वॉल्यूम डिक्रीज होगा तो प्रेशर इज गोइंग टू इंक्रीज फ्रॉम 0 इट इंक्रीजेस टू plus 1 mm of Hg एंड एट द एंड ऑफ एक्सपिरेशन हमारा अगेन alveolar pressure क्या हो जाएगा? 0. So see, this is the curve. Inspiration में क्या होगा? Volume is going to increase, so pressure is going to decrease. This is the curve for intra-alveolar pressure ना. तो at the resting condition कितना होता है? 0. ठीक है, at the इंस्पिरेशन की बात क्या होगा? इट बिकम मोर नेगेटिव, इट बिकम minus 1 mm of Hg एंड एट द एंड ऑफ इंस्पिरेशन क्या होगा? अगेन बिकम 0. ठीक है, एंड एक्सपिरेशन के वक्त क्या होगा? वॉल्यूम इज गोइंग टू डिक्रीज, सो प्रेशर इज गोइंग टू एक्सपिरेशन क्या होगा? वॉल्यूम इज गोइंग टू डिक्रीज, सो प्रेशर क्या होगा? प्रेशर इज गोइंग टू इंक्रीज. सो 0 से it comes to plus 1 mm of Hg and at the end of expiration it again reaches to 0. This is about alveolar pressure. Clear? Moving further to the next, that is transpulmonary pressure. It is a derived pressure. It is equal to alveolar pressure minus pleural pressure and they are responsible for the opening of the slum. ठीक है, रेस्टिंग कंडीशन में हमारा alveolar प्रेशर कितना होता है? 0. रेस्टिंग कंडीशन में हमारा इंट्राप्ल्यूरल प्रेशर कितना होता है? minus 2.5 mm Hg. So at the resting condition the transpulmonary pressure is 2.5 mm of Hg. मूविंग टू द समरी, प्रेशर वॉल्यूम चेंजेस ड्यूरिंग ब्रीदिंग की बात करेंगे. तो ड्यूरिंग इंस्पिरेशन क्या हो रहा है? Volume is going to increase, pressure is going to decrease. So intrapleural pressure decreases, alveolar pressure decreases. Intrapleural pressure become minus 6 mm of Hg, alveolar pressure become minus 1 mm of Hg. Expiration की बात करेंगे तो volume is going to decrease, so pressure is going to increase. So intrapleural pressure is going to increase and it reaches to minus 2.5 mm of Hg. ठीक है? And alveolar pressure also going to increase, so it reaches to plus 1 mm of Hg. Is this clear with everybody? Do reply fast. Is this clear? So moving further, this is the diagram. So during inspiration, volume is going to increase, so pressure is going to decrease, so alveolar pressure also decreases, intrapleural pressure also decreases, and during expiration, volume is going to decrease, so pressure is going to increase, so alveolar pressure increases, intrapleural pressure also increases. So moving further to the muscles of breathing. अगर नॉर्मल क्वाइट ब्रीदिंग की बात करेंगे तो हमारा इंस्पिरेशन कैसा है? एक्टिव प्रोसेस है एंड एक्सपिरेशन इज पैसिव प्रोसेस. सो इंस्पिरेशन में the most important one is the diaphragm. Diaphragm play an important role in our inspiration. Accessory muscles are also there that are involved in inspiration is sternocleidomastoid, sclerae muscle and external intercostal muscle. These three muscles are accessory muscle for the inspiration. So see, this is the diagram. Go via the recoil of lung and the rib cage. Active expiration are due to internal intercostal, rectus abdominis, obliquus and transverse abdominis muscle. These are required for active expiration. Is this clear? Moving further, same thing is written out here. Expiration normally तो passive होता है. During exercise it involves internal intercostal, rectus abdominis, transverse abdominis. Now coming to the compliance. So what is the compliance? Compliance क्या होगा? हमारा inspiration के बाद air moves to our alveoli and the stretching of alveoli due to inspiration is the compliance. The stretching ability of alveoli or distension ability of alveoli is the compliance. Is this clear? What is compliance? Stretching of alveoli is compliance. Moving further, there are two forces that opposes this stretching of alveoli. First is the surface tension that is exerted by the water molecule. Second one is the elastic recoil, elastance or the elasticity. This also opposes the stretching of alveoli. So we can say this compliance is inversely proportional to the elastance and it is inversely proportional to the surface tension. So in emphysema अगर डिजीज की बात करते हैं तो लंग की इलास्टिसिटी क्या हो जाती है? डिक्रीज हो जाती है एंड इलास्टिसिटी डिक्रीज होगी तो कॉम्प्लायंस क्या हो जाएगा? इंक्रीज हो जाएगा. सो वी कैन से इन emphysema कॉम्प्लायंस इंक्रीजेस. सो अगर कॉम्प्लायंस इंक्रीज हो जाएगा तो स्ट्रेचिंग ऑफ alveoli विल बी मोर एंड स्ट्रेचिंग ज्यादा होगी तो हमारे लंग में क्या होगा? ओवर डिस्टेंशन विल बी सीन एंड ओवर डिस्टेंशन की वजह से हमारे लंग में हाइपर इन्फ्लेशन एरिया विल बी सीन. Is this clear? Moving further, in restrictive lung disorder अगर pulmonary fibrosis की बात करते हैं तो उस सिचुएशन में क्या है कि हमारा compliance decrease होता है. So do remember, in obstructive lung disease हमारा compliance increase होता है, in restrictive lung disorder compliance decreases. अगर normal compliance of lung की बात करते हैं it is 200 ml per centimeter of water. Compliance को हम इस तरह भी कह सकते हैं for given change in a volume the pressure, for given change in a pressure the volume change in our alveoli. The volume change means stretching of our alveoli, that is compliance. So we can say compliance is for given change in a pressure the volume change is compliance. Is this clear with everybody? So this is the normal compliance curve between the change in lung volume with the change in pressure. So this is the normal compliance curve. अब आ जाएंगे लो compliance curve और high compliance curve. Emphysema में क्या होता है? टिश्यू की elasticity more होती है, there will be more stretching. So situation में for given change in a pressure, the volume change is more. So see, this is the curve. For given change in a pressure, the volume change is very more. So that's why it is a high compliance curve. और ये कब मिलेगा हमें? Emphysema में मिलेगा. Low compliance curve कब मिलता है? जब for given change in a pressure, the volume change is very low. So this is a compliance, कैसा compliance curve है? Low compliance curve है, and this is seen in pulmonary fibrosis. Restrictive lung disorder में क्या होगा? Compliance is less, and obstructive lung disorder में क्या होगा? Compliance is more. Is this clear with everyone? Moving further, same thing is written out here. In restrictive lung disorder, lung will not distend on increasing pressure. So that's why we'll get this poor compliance and curve will comes down. Coming to the next type of compliance. So compliance हमारा दो तरह से हो सकता है, static compliance और the dynamic compliance. First coming to this static compliance. Compliance during the breath holding situation is the static compliance. ठीक है, and normal value जो अभी अपने बात की थी, normal compliance कितना होता है? 200 ml per centimeter of water. This is our static compliance. Next is the dynamic compliance. As the name suggests, it changes with the time. So it changes with the stage of breathing. At the start of inspiration, देखो इसको explain करते हैं. At the start of inspiration, alveoli क्या होती है? Alveoli are smaller. And alveoli small होगी तो surfactant का distribution lower area में होगा, तो surfactant का concentration क्या होगा? More होगा. तो surface tension यहाँ पे क्या होगा? ज़्यादा reduce होगा. तो surface tension overall क्या हो जाएगा? Low हो जाएगा. And we all know compliance is inversely proportional to the surface tension. So surface tension यहाँ पे less है smaller compliant में, so compliance is more. So at the start of inspiration compliance is more, at the end of inspiration क्या होगा? Alveoli हो जाएगी large, surface tension is more. ठीक है सर, क्योंकि surfactant क्या हो जाएगा? Higher area में distribute हो जाएगा, तो surface tension reduce कम होगा, surface tension overall क्या होगा? More. So compliance is less in this situation. Next is the derived compliance, that is specific compliance. Specific compliance क्या होता है? Normal compliance upon FRC is going to give this specific compliance. Of breathing. To understand the mechanism of breathing, do remember the Boyle's law. What is Boyle's law state? Pressure is inversely proportional to the volume. When volume in the lung is going to increase, so pressure of the lung is going to decrease. So in physiology or in our respiratory physiology, the volume we are talking is tidal volume. The pressure which we are talking about are three lung pressure. That is intrapleural pressure, alveolar pressure and the transpulmonary pressure. ठीक है, three pressures: intrapleural pressures, alveolar pressure, transpulmonary pressure. First coming to this intrapleural pressure. As the name suggests, it is between the two layers of the pleura. So at resting condition, the intrapleural pressure is negative and it is minus 2.5 mm of Hg. So do remember this one. So what happened? It become positive only and only during forceful expiration. Rest normal respiration की बात करेंगे, it is always and always negative. Now coming to the point why it is negative. Our pleural membrane is attached to lung from one side and it is attached to chest wall at the other side. Chest wall has tendency to move outside while lung has tendency to collapse. So क्या होगा? Pleura is stretched by these two opposing forces and these two opposing forces की वजह से क्या होगा? A vacuum-like state is created between these two pleural layer and that is responsible for this intrapleural pressure negative. So now coming during inspiration क्या होगा? Volume of the lung is going to increase, so pressure is going to decrease because Boyle's law states that pressure is inversely proportional to the volume. हमारा रेस्टिंग कंडीशन में प्रेशर कितना है? इट इज माइनस 2.5 mm of Hg. अब प्रेशर और फॉल करेगा, इट रीचेस टू माइनस 6 mm of Hg, मीन्स इट बिकम मोर नेगेटिव. Now coming to the situation during expiration क्या होगा, volume of lung is going to decrease, so pressure is going to increase. So -6 से ये increase होके it reaches to -2.5 mm of Hg. That's how our intrapleural pressure changes during breathing. Is this clear, everybody? So moving further to the alveolar pressure. Second pressure is alveolar pressure. At resting condition, this alveolar pressure is 0. During inspiration क्या होगा? During inspiration, volume of lung is going to increase, so the alveolar pressure is going to decrease. So from 0 it decreases to -1 mm of Hg. So at the end of inspiration क्या हो जाएगा? At the end of inspiration, alveolar pressure हमारा 0 हो जाएगा, and from -1 it reaches to 0. Is this clear? Now coming to the expiration. Expiration में क्या होगा? Volume of lung is going to decrease, so pressure increases. So from 0 it increases to +1 mm of Hg, and same at the end of expiration alveolar pressure again becomes 0. ठीक है, तो किस तरह चेंज हुआ? Resting condition पे it is 0. Inspiration के टाइम it become more negative, it become -1 mm of Hg. At the end of inspiration it again becomes 0. फिर हमारा एक्सपिरेशन स्टार्ट करेंगे तो एट द एक्सपिरेशन क्या होगा? इट बिकम पॉजिटिव, इट इंक्रीजेस एंड इट बिकम +1 mm of Hg, and at the end of expiration it again becomes 0. That's how our alveolar pressure changes during breathing. Is this clear? Moving further to this diagram, हमारा this is the first curve which is showing intra-alveolar pressure. Second is the breathe volume. During inspiration volume increases, during expiration volume decreases. ठीक है, अब बात करेंगे प्रेशर की. तो ड्यूरिंग इंस्पिरेशन क्या होगा? वॉल्यूम इंक्रीजेस, सो प्रेशर इज गोइंग टू डिक्रीज. सो फ्रॉम 0 विच इज एट द नॉर्मल कंडीशन, फ्रॉम 0 इट डिक्रीजेस टू -1 mm of Hg. ठीक है, एंड एट द एंड ऑफ इंस्पिरेशन इट अगेन बिकम्स 0. एक्सपिरेशन में क्या हुआ? वॉल्यूम इज डिक्रीजिंग, सो प्रेशर इज गोइंग टू इंक्रीज, सो इट इंक्रीजेस टू +1 mm of Hg, and at the end of expiration it again becomes 0. That's how our alveolar pressure changes during breathing. Is this clear with everyone? Moving further to the next pressure, that is transpulmonary pressure. This transpulmonary pressure is the right one. It is equal to alveolar pressure minus pleural pressure. And this transpulmonary pressure is responsible for the opening of lung during the inspiration. So at rest हम कह सकते हैं alveolar pressure कितना होता है? 0. Pleural pressure कितना होता है? -2.5 mm of Hg. So at the resting condition this alveolar pressure is +2.5 mm of Hg. Is this clear with everybody? Now moving to the next one, that is pressure volume changes during breathing. ड्यूरिंग इंस्पिरेशन क्या हुआ? सबको समराइज कर रहे हैं, बिल्कुल ध्यान से देखना. ड्यूरिंग इंस्पिरेशन वॉल्यूम ऑफ द लंग इज गोइंग टू इंक्रीज, सो बोथ द प्रेशर इज गोइंग टू डिक्रीज, इंट्राप्लूरल प्रेशर एज वेल एज एल्वेलर प्रेशर. तो इंट्राप्लूरल प्रेशर फ्रॉम -2.5 इट रीचेस टू -6 mm of Hg. एल्वेलर प्रेशर की बात करेंगे तो फ्रॉम 0 इट डिक्रीजेस टू -1 mm of Hg ड्यूरिंग एक्सपिरेशन. नाउ during expiration क्या होगा? volume in the lung is going to decrease, so since volume is decreased pressure is going to increase, so both intrapleural as well as alveolar pressure is going to increase. So intrapleural pressure -6 से हमारा पहुंच जाता है -2.5 mm of Hg. alveolar pressure from -1 से ये again 0 आ जाता है at the end of inspiration. ठीक है, और from 0 it reaches to +1 mm of Hg. Is this clear with everybody? So during resting condition अगर हम intrapleural pressure write करते हैं तो resting condition पे it is -2.5 mm of Hg. After inspiration it reaches to -6 mm of Hg. ठीक है, after expiration it again become -2.5 mm of Hg. alveolar pressure फिर से summarize कर लेते हैं. resting condition में it is 0. inspiration के बाद it become negative, it become -1 mm of Hg. At the end of inspiration it again becomes 0. expiration में it is going to increase, so it increases to +1 mm of Hg. At the end of inspiration it again becomes 0. So that's how our alveolar pressure changes. Is this clear with everybody? Do reply fast. Is this clear? Moving further to this diagram. What happened? Inspiration में हमारा volume is increasing and expiration में volume is decreasing. So first is the alveolar pressure. Alveolar pressure हमारा 0 से -1 होगा, then again becomes 0, then +1, then 0. Now coming to the intrapleural pressure, which is at the resting condition -2.5 mm of Hg. From there it reaches to -6 mm of Hg, and at the end of expiration it again reaches to -2.5 mm. Moving further to the muscles required for the breathing. Normal breathing की बात करेंगे तो हमारा inspiration is active process while expiration is passive process. So now coming to the muscle that is required for inspiration. The most important out of all is diaphragm. Along with that we have certain accessory muscle like sternocleidomastoid, sclani muscle and external intercostal muscle. All these three muscles are required for inspiration. Diaphragm, the most important accessory muscles are sternocleidomastoid, sclani muscle and external intercostal muscle. Now moving to the diagram, this is the diagram. हमारा जो expiration at the normal situation is passive. It occurs by the recoil of lung and the rib cage. To remember this point. Active होता है हमारा inspiration ना, तो उसमें हमारा required होता है sternocleidomastoid, sclani muscle, external intercostal as well as diaphragm, the most important one. ठीक है, but certain expiration is हमारा active, like forceful expiration during exercise are active expiration, and in that situation the muscle involved are internal intercostal, rectus abdominis, obliquus and transverse abdominis. These are the muscle that is required during active expiration. Same thing is written out here. During expiration, the muscle required are internal intercostal, rectus abdominis and transverse abdominis. Now coming to the next topic, that is compliance. जिस पे काफी सारे questions आते हैं. What is compliance? First of all, what is compliance? The stretching or distension ability of our lung alveoli is known as compliance. ठीक है, इसको देख second point आ जाते हैं. What are the opposing forces for this compliance? Surface tension. The surface tension is exerted by the water molecule which is lining our alveoli. ठीक है. Next is the elastic recoil of our alveoli is also going to oppose this compliance. So we can say this one, compliance is inversely proportional to the elasticity of alveoli and it is inversely proportional to the surface tension which is exerted by the water molecule. So now coming to the emphysema. In emphysema what happened? Lung elasticity decreases. So when lung elasticity is going to decrease, compliance is going to increase. So lung elasticity decreases, compliance increases, and we all know compliance is the stretching of alveoli. So out here there will be more stretching of alveoli and that is going to cause this over distension of lung, and in X-ray we are going to see this hyperinflation areas. Is this clear? Moving further, in restrictive lung disorder like pulmonary fibrosis, compliance decreases. Okay? This is the normal compliance of lung, that is 200 ml per centimeter of water. And we can say compliance is for given change in a pressure, the volume change in our alveoli is the compliance. So do remember, obstructive lung disorder में compliance increases and in restrictive lung disorder our compliance decreases. Normal compliance कितना होता है? 200 ml per centimeter of water. Compliance क्या है? For given change in a pressure, the volume change in alveoli is compliance. Moving further to this diagram, this is the normal compliance because this is the curve between change in a pressure for change in a volume. ठीक है? For given change in a pressure, the volume changes our compliance. ठीक है? So this is the curve of compliance. And this is the normal compliance, and in first curve, this red one, what we all are seeing in this red compliance for given change in a pressure, the volume changes more. So this is the curve of high compliance, and high compliance किस केस में होता है? Emphysema. And for this blue one, what we all are seeing, for given change in a pressure, the volume change is low. So कैसा कर्व हो गया, ये हमारा लो कॉम्प्लायंस कर्व हो गया. एंड लो कॉम्प्लायंस कर्व किस केस में होता है, पल्मोनरी फिब्रोसिस. Is this clear, everybody? Moving further, same thing is written out here. In restrictive lung disorder, lung will not distend on increasing pressure. So compliance कैसा होगा, poor. So curve will calm down. Moving further, different type of compliances are there. First is static compliance. This is the compliance during the breath holding situation, and it is 200 ml per centimeter of water. Next is the dynamic compliance. As the name suggests, it will changes with the stage of breathing. So what happened at the start of inspiration, our alveoli are smaller. So इस small area में हमारा surfactant distribute होगा, तो higher concentration of surfactant will be there. So surface tension reduced out here is more. So overall surface tension क्या होगा यहाँ पे low. And we all know compliance is inversely proportional to the surface tension. So surface tension is low. So compliance at the start of inspiration is more. Is this clear with everybody? अब बात करेंगे at the end of inspiration क्या हो गया, हमारी alveoli become large. So larger area में surfactant distribute होगा. So concentration of surfactant reduces. So surface tension reduced out here is also less. So overall surface tension यहाँ पे क्या हो जाएगा, that is more. So compliance is less. So what we all are seeing, at the start of inspiration compliance is more, at the end of inspiration compliance is less. So what we all are seeing, compliance is changing. So it is a dynamic compliance. Next is the specific compliance. It is the derived one. Normal compliance upon FRC is our specific compliance. Is this clear with everybody? Moving further to the compliance curve during inspiration and expiration. This is the compliance curve during inspiration. This is the compliance curve during expiration. So what we all are seeing, that compliance change during inspiration is not coinciding with the compliance change during expiration, and that is going to cause this gap between these two curves, and this is known as hysteresis. So we can say hysteresis is indicating that compliance change during inspiration is not coinciding with the compliance change during expiration. अब ये क्यों हुआ? See, at the start of inspiration our alveoli are small, compliance is more. At the end of inspiration our alveoli are larger, so compliance is less. At the end of expiration हमारा, at the start of expiration alveoli are large, compliance is less. At the end of expiration is alveoli is small and compliance is more. So compliance change during inspiration is not coinciding with the compliance change during expiration, and that is the cause of this hysteresis. So we can say this hysteresis is due to, firstly we can say it is due to difference in compliance, and this difference in compliance is due to surfactant concentration. So we can say this hysteresis is also due to this surfactant. Is this clear? And the surfactant is responsible for hysteresis. Do remember. Moving further, steep portion of a curve. Yeah, what does it indicate? It indicates that for a small pressure changes, volume changes more, and that is indicating the good compliance. So a steep portion of compliance curve is indicating the good compliance. While flat portion क्या indicate करता है? Flat portion indicate that for given change in a pressure, volume change is less or there is no volume change, and that is indicating the poor compliance. So do remember, steep portion indicate good compliance, flat portion indicate poor compliance. Moving further, highest compliance कब होता है? At the end of expiration. Lowest compliance कब होता है? At the end of inspiration. So we can say hysteresis is due to the surface tension, and this surface tension is due to water molecule. So when we wash our lung with the saline, surface tension will be removed, and so there will be no hysteresis. So this point is important from the exam point of view. In saline washed lung, there is no surface tension and there is no hysteresis. Is this clear with everyone? Do reply fast. Is this clear? अभी तक सेशन में किसी को कोई डाउट है तो क्लियर कर सकते हैं. Anybody any query till now you can ask in this session only. So moving further, this is the diagram. This is air-filled lung where we are seeing this hysteresis is there, and this is saline-filled lung where there is no hysteresis. Moving further, this is the compliance curve with free compliance. Compliance of chest wall, compliance of lung, and total compliance. This is the curve for compliance of chest wall. This is the curve for compliance of lung, and this is the compliance for whole respiratory system. So in this we are seeing this is the point where the compliance of chest wall and lung is balanced out, and this point is corresponding to our FRC. So moving further, there are two forces that opposes our thorax. First is chest wall, second one is lung. Chest wall has tendency to move out, lung has tendency to collapse, and there is a point वहाँ जहाँ पे ये balance out हो जाता है, that is known as balancing point or equilibrium point, and this balancing point or equilibrium point corresponds to our FRs. Is this clear? Moving further to the work of breathing. ठीक है, वर्क कब होता है? जब हमारा एयर लंग इनहेल करता है या एक्सहेल करता है, दैट इज द वर्क डन. नॉर्मल वर्क डन कितना होता है हमारा लंग का? दैट इज 0.5 किलोग्राम पर मीटर पर मिनट. दिस इज द फॉर्मूला. वर्क इज इक्वल टू फोर्स डिस्प्लेसमेंट. फिजिक्स में सभी ने पढ़ा होगा. Out here the force is our change in pressure, displacement is change in volume. अब work को classify करेंगे. Work is classified into two categories. 65% is the major work done and 35% is the minor work done. कैसे होता है distribute? Major work done क्या हुआ, minor क्या हुआ? Major work done is 65% ना. 65% is the major one, and that is to overcome this elastic forces. ठीक है, 1/3 हमारा जो वर्क डन है सरफेस टेंशन को ओवरकम करने में जाता है, एंड 1/3 इज गोइंग टू ओवरकम दिस टिश्यू इलास्टिसिटी, एंड हमारा जो रेस्ट 35% माइनर वर्क डन है. दिस माइनर वर्क डन इज टू ओवरकम दिस रेजिस्टेंस, जिसमें 28% क्या है एयरवे रेजिस्टेंस है, एंड 7% इज टिश्यू रेजिस्टेंस. एंड इन COPD हमारा एयरवे रेजिस्टेंस इंक्रीज हो जाता है, और अगर इंटरस्टिशियल लंग डिजीज की बात करें तो इंटरस्टिशियल लंग डिजीज में टिश्यू रेजिस्टेंस इंक्रीजेस. सो दिस इज द क्लिनिकल एस्पेक्ट. डू रिमेंबर, इन COPD एयरवे रेजिस्टेंस इंक्रीज होता है, एंड इन इंटरस्टिशियल लंग डिसऑर्डर टिश्यू रेजिस्टेंस इंक्रीजेस. Is this clear with everyone? Moving further to the lung volume and the lung capacity. This lung volume and lung capacity is measured by a spirometer, and that spirometer is known as Hutchinson spirometer. So we have two types of lung volume, static lung volume and the dynamic lung volume. Static lung volume में क्या होगा? टाइम फैक्टर इज नॉट देयर. डायनामिक लंग वॉल्यूम में क्या है? इट इज टाइम डिपेंडेंट. इसमें हमारा आ जाएगा FEV1, फोर्स एक्सपायरेटरी वॉल्यूम इन 1 सेकेंड, फोर्स एक्सपायरेटरी वॉल्यूम इन 2 सेकेंड, फोर्स एक्सपायरेटरी वॉल्यूम इन 3 सेकेंड. This dynamic lung volume is important from the exam point of view because it is important for the diagnosis of respiratory disorder. So इसी से हम क्लासीफाई कर दें कि किस टाइप का रेस्पिरेटरी डिसऑर्डर है. ठीक है, अब इसी को डिटेल में देखेंगे. फर्स्ट कमिंग टू द स्टैटिक लंग वॉल्यूम, इसमें फर्स्ट वन इज आर टाइडल वॉल्यूम. सो इन स्टैटिक लंग वॉल्यूम एंड capacity, we have the first one, that is tidal volume. What is tidal volume? The amount of air that we inhale and exhale during normal breathing is our tidal volume. And इसकी value कितनी होती है? Its normal value is 500 ml. Next is inspiratory reserve volume. The amount of air that can be maximally breathed in beyond a normal inspiration. नॉर्मल इंस्पिरेशन के बाद जो मैक्सिमली हम ब्रीद इन कर सकते हैं दैट इज इंस्पायरेटरी रिजर्व कैपेसिटी एंड इट्स नॉर्मल वैल्यू इज 2 to 3 लीटर. नेक्स्ट इज एक्सपायरेटरी रिजर्व वॉल्यूम. आफ्टर नॉर्मल एक्सपिरेशन द अमाउंट ऑफ एयर व्हिच we can forcefully breathe out is our expiratory reserve volume and its normal value is 1300 ml. Next is the residual volume. The amount of air that remain in lung after forceful expiration is our residual volume and its normal value is 1200 ml. Next is the closing volume, newly added one है. क्या होता है? At the end of expiration जो basal region of lung में alveoli होती है, they start to close and when it close it entraps some volume of air and that is known as this closing volume. And this closing volume increases with the age. Moving further to this diagram, this is the tidal volume, the amount of air that we can breathe in or breathe out normally. Inspiratory reserve volume, the amount of air that we can inspire beyond a normal inspiration. Expiratory reserve volume is amount of air that we can exhale out after normal expiration. What is residual volume? The amount of air that remain in lung after forceful expiration is our residual volume. So these are the volume. Now coming to the static capacities. First is the inspiratory capacities. Inspiratory capacity क्या हुआ? हमारा tidal volume plus inspiratory reserve volume is our inspiratory capacity. Next is the FRC, functional residual capacity. ठीक है, FRC is equal to expiratory reserve volume plus residual volume and its value is 2.5 liter. ठीक है, do you remember the FRC is 2.5 liter. FRC क्या हो गया? हमारा volume of air that remain in lung after the end of normal expiration. Normal expiration के बाद हमारा volume कौन-कौन सा बच जाता है लंग में? FRC plus expiratory reserve volume plus residual volume. That is our functional residual capacity. Next is the vital capacity. Vital capacity क्या होता है? The volume of air that we can maximally exhale out after maximal inspiration. So maximal inspiration के बाद हम यहाँ पहुँच गए. Maximal inspiration के बाद हम जो maximally exhale out कर सकते हैं, that is inspiratory reserve volume plus tidal volume plus expiratory reserve volume. So this is our vital capacity. Is this clear? So vital capacity is a summation of expiratory reserve volume, tidal volume and expiratory reserve volume. So its normal value is 3.8 to 4.5 liter. Next is the total lung capacity. This total lung capacity is summation of tidal volume plus inspiratory reserve volume plus expiratory reserve volume plus residual volume. So we can say it is the summation of vital capacity plus residual volume and its normal value is 5 to 6 liter. FRC कितना था? FRC was, normal FRC is 2.5 liter and total lung capacity is 5 liter. So we can say this FRC is equal to 50% of total lung capacity. And अभी हमने पढ़ा था FRC is also known as equilibrium point and the midpoint. Is this clear with everybody? Now coming to the next important point. There are some volume, there are some capacity which cannot be measured by this Hutchinson spirometry. कौन सा volume हम measure नहीं कर सकते? We cannot measure this residual volume. So when we cannot measure this residual volume, we cannot measure this FRC because FRC is summation of expiratory reserve volume plus residual volume, and we cannot measure this total lung capacity because total lung capacity also consists of this residual volume. So this point is important. From Hutchinson spirometer we cannot measure the residual volume, we cannot measure the expiratory reserve. FRC we cannot measure the total lung capacity. Is this clear with everybody? समझ में आया? Static lungs and static lung volume and capacity is everybody. Is this clear? So moving further. Now, how does FRC is measured? अगर spirometry से हम measure नहीं कर सकते तो there are some alternate method जिससे हम FRC measure करते होंगे. So there are some methods from which we measure this FRC. First method is helium dilution method. ठीक है, helium dilution method में क्या होता है? A patient is connected to a chamber जिसमें हम known concentration and known volume of helium को add करते हैं and it is connected to patient mouth. So after certain period of time क्या होगा? This helium is going to diffuse into the lung and after certain period of time our diffusion stop हो जाएगा because equilibration achieve हो जाएगा. So after equilibrium concentration हमारा remain same before and after. So initial हमारा amount of helium is equal to initial concentration of helium into initial volume of helium. Final mass of helium is final concentration C2 and final volume that is V1 plus FRC. So this is the formula जिससे हम FRC calculate करते हैं via this helium dilution method. ठीक है? Is this clear? So mass conservation लगा के हमने helium dilution method से FRC को calculate कर लिया. Next technique that is nitrogen washout method. इसमें हम nitrogen use करते हैं and this is the formula. C1 V1 upon C2 is going to give this FRC. इसमें क्या करते हैं? Patient is asked to breathe in pure oxygen and he has to asked to expire in nitrogen meter. अब nitrogen meter से क्या होगा? Expired air में nitrogen content आ जाता है and इस formula से we calculate the FRC. C1 V1 upon C2 give us this FRC. Coming to the next one, that is the most commonly used method to measure the FRC is body plethysmography. इसमें क्या करते हैं? Subject is enclosed in a box and he is asked to breathe in and breathe out in that closed box only. So what happened when he breathe in a closed box, volume of a box is going to decrease. So we all know by the Boyle's law pressure is inversely proportional to the volume. So volume of box decrease हो रहा है तो pressure of box क्या हो जाएगा? Increase. और lung के level पे बात करते हैं तो inspiration की वजह से lung में volume increase होगा. So pressure of lung is going to decrease. So this is the formula जिससे हम we calculate this FRC. Pressure हम किस level पे measure करते हैं? We measure the pressure at the level of mouth. So do remember, volume is measured at the level of lung while pressure is measured at the level of mouth. ठीक है? Volume at the level of lung, pressure at the level of mouth is calculated. So inspiration के बाद क्या होगा? हमारा volume of lung increase होगा, pressure of lung is going to decrease. So this is the formula. यहाँ पे भी हम mass conservation लगाएंगे. Pressure of mouth initial into volume of lung initial is equal to pressure of mouth final into volume of lung final. So volume of lung final को हम लिख सकते हैं volume of lung initial plus change in volume. This is our final volume. So in this we can see this diagram. A patient is enclosed in a closed chamber and is asked to breathe in and breathe out. And during inspiration क्या हो जाएगा? During inspiration pressure volume of lung is going to increase, so pressure of lung is going to decrease. Box के बारे में बात करेंगे तो volume of box is going to decrease, so pressure of box is going to increase. Pressure is measured at the level of mouth, volume is measured at the level of lung. So this is the formula. Pressure of mouth initial into volume of lung initial is equal to pressure of mouth final plus volume of lung final, that is volume of lung initial plus change in volume, and this volume of lung initial is our FRC. So body plethysmography से हम FRC रेशियो करते हैं. So कौन से टेक्निक हो गए? First is helium dilution, second is nitrogen washout, and next one is body plethysmography. All these three methods are used to measure the FRC. Is this clear with everybody? Proceed करते हैं further. Now coming to after static lung volume and capacity, now coming to the dynamic lung volume and capacity. This dynamic lung volume is responsible for diagnosis of respiratory disorders. So this is important from the exam point of view. So now coming to the most important point, how this force vital capacity or force vital capacity को measure करते हैं. In this, patient is asked to have a deep inspiration, and now he has to start the expiration, but expiration should be, first point, it should be fast, it should be forceful, and it should last for 6 seconds. कैसा होना चाहिए एक्सपिरेशन? एक्सपिरेशन शुड बी फास्ट, forceful, and it should last for 6 seconds. This is all three points are important for measuring this force vital capacity. ठीक है, तो इसमें we have certain type of force vital capacity, that is force expiratory volume in 1 second, force expiratory volume in 2 seconds, and force expiratory volume in first 3 seconds. Now coming to the first one, the force expiratory volume in first second is equal to 70 to 80% of our force vital capacity. यानी हमारा force vital capacity का almost 80% expired हो जाता है during first second only. ठीक है, and this ratio is known as Tiffany index. कौन सा ratio? FPV1 upon force vital capacity ratio is R 70 to 80%, and this is known as Tiffany index. ठीक है, ऑब्स्ट्रक्टिव लंग डिसऑर्डर की अगर बात करेंगे तो ऑब्स्ट्रक्टिव लंग डिसऑर्डर में दिस टिफैनी इंडेक्स डिक्रीजेस, व्हाइल इन रिस्ट्रिक्टिव लंग डिसऑर्डर this either remain normal or increases. This Tiffany index decreases in obstructive lung disorder. This Tiffany index increases in restrictive lung disorder. Do remember. Force vital capacity in first 2 seconds is 95%. Force vital capacity in first 3 seconds is almost 99 to 100%. Is this clear with everybody? Moving further to the flow volume loop. So this is a loop, not a plotted graph. Do not confuse with the graph. This is not a graph. This is only and only loop. And this is important because इससे हम different type of lung disorder को differentiate करते हैं. कैसे differentiate करते हैं? Let me draw this one for all of you. Okay, fine. We have this page. On y-axis we take the flow rate. On y-axis हमने फ्लो ले लिया, एंड ऑन एक्स एक्सिस वी टेक द वॉल्यूम. So now first we are drawing our inspiratory. So this is the point. ठीक है, जहाँ से हम डीप इंस्पिरेशन स्टार्ट कर रहे हैं. तो डीप इंस्पिरेशन से पहले हमारा वॉल्यूम ऑफ एयर इन आवर लंग इज आर FRC. So this point corresponds to our FRC. Now we are starting with this deep inspiration. So this is the inspiratory loop. ठीक है, ये लूप है, ग्राफ नहीं है, बिकॉज ग्राफ में हम अगर एक्स एक्सिस पे इस तरह मूव करेंगे तो वॉल्यूम डिक्रीजेस, बट यहाँ पे क्या हो रहा है? वॉल्यूम इज इंक्रीजिंग नॉट डिक्रीजिंग. सो डू नॉट टेक इट एज अ लूप. So sorry, don't take it as a graph, it is a loop. So this point, let me change the color first. This is the peak inspiratory flow rate. Y axis पे हमने flow लिया ना, तो this is the peak inspiratory flow rate, and this is 3 liters per second. And this is achieved after 50% of inspiration. This is inspiratory loop. So peak inspiratory flow rate is achieved after 50% of inspiration, and it is 3 liters per second. Now coming to the next, that is our expiratory loop. So this is the point जहाँ से we are starting the expiration. This is the curve for expiration. This is the peak expiratory flow rate. Peak expiratory flow rate, and its normal value is 10 to 12 liter per second, and it is achieved after 20% of expiration. So all these data are important. Do remember, peak inspiratory flow rate is achieved at 50% of inspiration is achieved, और जब हमारा expiration 20% हो जाता है तो peak expiratory flow rate is achieved, and that is 10 to 12 liter per second. This is a effort dependent part. This part is effort independent part. ठीक है, तो सारे डेटास याद रखना है. Peak inspiratory flow rate is 3 liter per second. Peak expiratory flow rate is 10 to 12 liter per second. Peak inspiratory flow rate is achieved when 50% of lung volume is inspired. Peak expiratory flow rate is achieved at 20% of lung volume expired. इसमें दो पार्ट हो गया, effort dependent part, effort independent part. First 20% is effort dependent, last 80% is effort independent. एफर्ट डिपेंडेंट में क्या होगा, जितना ज्यादा एफर्ट लगाएंगे फ्लो रेट इंक्रीज हो सकता है, so that's why it is known as effort dependent part. ठीक है, this point corresponds to our and इसमें next point is effort independent part is affected, and यहाँ पे क्या मिलेगा, we get this scooped out pattern, scooped out appearance or dog leg appearance. This is the scooped out or dog leg pattern. Let's see. So loop हमारा left shift हो गया. So what happened? The total lung capacity. This point corresponds to total lung. This total lung capacity includes. This point corresponds to residual volume. So residual volume increases, total lung capacity increases, and we already discussed this Stephani index decreases in this COPD. So क्या होगा, COPD में क्या होगा, हमारा compliance increase होगा, effort independent part affect होगा, loop shifted toward left होगा, dog leg pattern होगा, total lung capacity increases, residual volume increases, and the Stephani index decreases. Is this clear with everybody? Moving to the next situation, that is in restrictive lung disorder. Restrictive lung disorder में क्या होगा, curve is normal in shape, but the size is the miniature version, and the loop shifted toward the right. And जैसे right shift होगा तो हमारा total lung capacity decrease होगा, residual volume decreases, and our Tiffany index, force vital capacity, force expiratory volume in 1 second upon force vital capacity, this ratio either increases or remain normal. So this is the difference. बिल्कुल याद रखिएगा, during restrictive lung disorder compliance is going to decrease, flow volume loop is going to shift towards the right, and right shift की वजह से क्या होगा, total lung capacity decreases, residual volume decreases, and the Tiffany index increases or remain normal. So all these points are important. Is this clear with everybody? So now coming to the next कि हम इस loop से obstruction भी differentiate कर सकते हैं कि either it is a variable obstruction or fixed obstruction. Variable obstruction can be either extrathoracic या intrathoracic. इसको भी differentiate कर सकते हैं. कैसे differentiate कर सकते हैं? First situation, variable plus extrathoracic obstruction है. एक्स्ट्रा थोरेसिक ऑब्स्ट्रक्शन जब भी होगा तो हमारा इंस्पायरेटरी फेज विल बी अफेक्टेड, दिस इंस्पायरेटरी लूप विल बी अफेक्टेड, ठीक है, एंड दिस is including our obstructive sleep apnea and the paralyzed vocal cord. इन दोनों ही सिचुएशन में क्या होगा, इंस्पायरेटरी लूप अफेक्ट होगा एंड दिस इज द सिचुएशन. कमिंग टू द नेक्स्ट वन, वेरिएबल इंट्राथोरेसिक ऑब्स्ट्रक्शन. इंट्राथोरेसिक ऑब्स्ट्रक्शन में एक्सपायरेटरी लूप अफेक्ट होगा एंड फॉर एग्जांपल ट्रैकियल ट्यूमर, दिस ट्रैकियल ट्यूमर इज इंट्राथोरेसिक वेरिएबल ऑब्स्ट्रक्शन. लास्ट ऑब्स्ट्रक्शन दैट इज फिक्स्ड ऑब्स्ट्रक्शन. फिक्स्ड ऑब्स्ट्रक्शन जब भी होगा तो हमारा बोथ इंस्पिरेशन एंड एक्सपिरेशन विल बी अफेक्टेड एंड दिस इज सीन ड्यूरिंग द फॉरेन बॉडी ऑब्स्ट्रक्शन और द स्कैरिंग ऑफ एयरवे. तो इस तरह से हम फ्लो वॉल्यूम लूप से डिफरेंट टाइप ऑफ रेस्पिरेटरी डिसऑर्डर को डिफरेंशिएट करते हैं. इज दिस क्लियर विद एवरीवन? डू रिप्लाई फास्ट. किस तरह से हम डिफरेंशिएट करते हैं कि इट इज सीओपीडी और आवर रेस्ट्रिक्टिव लंग डिसऑर्डर, ठीक है, किस तरह से हम डिफरेंशिएट करते हैं डिफरेंट टाइप ऑफ ऑब्स्ट्रक्शन को. एवरीवन, इज दिस क्लियर? डू रिप्लाई फास्ट. इज दिस क्लियर? बिकॉज आई गेस इसके बाद क्वेश्चन पार्ट स्टार्ट होगा, तो अभी तक सेशन में किसी को कोई डाउट है तो क्लियर कर सकते हैं. एनीबॉडी एनी क्यूरी टिल नाउ यू कैन आस्क इन द सेशन ओनली. So moving further to the first question of today's session. The surfactant production in lung starts at 28 week, 32 week, 34 week or 36 week. Starts from 28th week. Answer is A. Coming to the next one. Surfactant is produced by type 2 pneumocyte, type 1 pneumocyte, macrophages or the endothelial cell. Yeah, very true. It is produced by type 2 pneumocytes. Coming to the next one, surfactant is made up of, or in human body the action of surfactant is done by fibrin, mucoprotein, phospholipid and protein or the fibrinogen. Surfactant is made up of, is it, I guess it is made up of phosphoprotein, phospholipid and the protein. Coming to the next, the main part of surfactant is formed by dipalmitidol, phosphatidylcholine, phosphatidyl inositol, dipalmitidol, cephalin, dipalmitidol, serine. The main part of surfactant is formed by are dipalmitidol, phosphatidylcholine. Next is option A. Pulmonary surfactant is secreted from 26 week of gestation and maintain minimal alveolar integrity. In hyaline membrane disease deficiency occur. Therapeutic application is seen. Evident secretion in bronchoalveolar carcinoma. It is a mucin and it is secreted by type 1 pneumocyte. Which of the statement are correct? It is secreted by 26th week of gestation and it maintains minimum alveolar integrity. In hyaline membrane disease deficiency occur and therapeutic application is also seen because we already studied drug form of our surfactant, mucinactin and baractin is used in deficiency of this surfactant. So next question, stability of alveoli is maintained by lung compliance, negative intrapleural pressure, increase in alveolar surface by the surfactant, residual air in the alveoli. Stability of alveoli is maintained by not compliance. Compliance is the stretching ability of alveoli. Alveoli की tendency क्या होती है? To collapse due to the surface tension exerted by water molecule. And यही surface tension को हमारा reduce करता है surfactant by increasing the alveolar surface. So answer is C. Is this clear, Dr. Bharve? Answer is not A, it is C. Coming to the next one. Correct about action of surfactant. It bind with the oxygen, lubricate carbon dioxide flow, make capillary surface hydrophilic, break structure of water in the alveoli. Correct statement about the action of surfactant. No, Dr. Bharve, it is not like that. What does surfactant do? फिर से revise कर लो. I guess आपने late से session join किया. This is our alveoli. It is lined with this water molecule. Water molecule has tendency to collapse the alveoli because it exerts the surface tension which has tendency to collapse the alveoli. And what does the surfactant do? Suppose this is our alveoli. This is lined by water molecule. This surfactant break this water structure. Okay? And so the surface tension caused by those water molecule decreases, and that's why it prevents the collapse of alveoli. So it breaks the structure of water in the alveoli. It increases the surface area of alveoli. Is this clear, everybody? Moving further to the next question, alveoli are kept dry because of surfactant, glycoprotein, buffer, or the Bose effect. So answer this question. I guess अब तो समझ में आ गया होगा alveoli are Hello Dr. Varsha, this is for the NEET PG. अगर आप NEET PG के लिए biology class देखना चाहते हो, you can follow the Let's Crack NEET UG. ठीक है, वहाँ पे जाके आप फॉलो कर लीजिए. चेक करना पड़ेगा आपको, थोड़ा सा वर्क करना होगा आपको खुद से. Alveoli are kept dry because of. Everybody answer this question. Do reply fast, everybody. Alveoli are kept dry because of. Obviously surfactant क्या कर रहा है हमारा water structure को break कर रहा है and it is keeping our alveoli dry. Next question. Hyaline membrane consists of albumin, fibrin, globulin, WBC. Hyaline membrane consists of this fibrin, fibrinogen and the debris product. Coming to the next one. True about inspiration. Intrapleural pressure become more negative, more positive, same, initially positive, then negative, or no relation is there. At the resting condition -2.5 होता है. Inspiration के बाद volume increase होगा, pressure is going to decrease, so it become more negative. Answer is A. Coming to the next one, the intrapleural pressure is negative both during inspiration and expiration because option A, intrapulmonary pressure is always negative. Thoracic cage and lung are elastic in nature. Transpulmonary pressure determine the negativity. Surfactant prevent the collapse of lung. क्या होता है, लंग की टेंडेंसी होती है टू कोलैप्स, thoracic wall की टेंडेंसी होती है to expand. So that's why two opposing forces are there and that is related to negative intrapleural pressure. So answer is B. Thoracic cage and lung are elastic in nature and force acting on both of them are opposite in direction. That's why intrapleural pressure is negative. Coming to the next one, same question है, skip करते हैं. Next, negative intrapleural pressure is due to uniform distribution of surfactant over the alveoli, negative intra-alveolar pressure, absorption of lymphatic and presence of cartilage in the upper airway. Shall everybody answer this question? Negative intra-alveolar. It is due to absorption of lymphatic. It is due to हमारा opposing force and this vacuum-like state is maintained by absorption of lymphatic. So we can say this absorption of lymphatic is also responsible for negative intrapleural pressure. Coming to the next question, true about normal expiration. At the end of normal expiration in air and lung is expiratory reserve volume. Chest wall has tendency to move outward, which is balanced by inward recoil of alveoli. In expiration, pleural pressure is equal to alveolar pressure. Muscles that elevate the chest case are classified as muscles of expiration. So everybody, normal inspiration is easier. Normal inspiration में क्या statement true है? Chest wall has tendency to move outward, which is balanced by inward recoil of alveoli. So false statement क्या था? At the end of normal expiration, volume in lung is RFRC, not expiratory reserve volume only. Expiration में pleural pressure is equal to alveolar pressure. That is wrong. Muscle that elevate the chest cage is defined as muscle of inspiration. So answer is only and only B. Coming to the next question. Next question. A person is having a normal lung compliance, but there is an increased airway resistance. The most economical way of breathing for him is rapid and deep, rapid and shallow, slow and deep, slow and shallow. Person is having a normal lung compliance, the best way, most economical way of breathing for him is, देखो उस सिचुएशन में क्या होगा, एयरवे रेजिस्टेंस इंक्रीज है तो स्लो एंड डीप ब्रीदिंग इज द मोस्ट इकोनॉमिकल वन. नो, रैपिड एंड डीप नहीं, इट इज स्लो एंड डीप. एयरवे रेजिस्टेंस इंक्रीज है, रैपिडली ब्रीथ करेंगे तो उसमें हमारा क्या होगा, एयरवे रेजिस्टेंस की वजह से जो एक्सेजरेशन है दैट इज गोइंग टू इंक्रीज व्हेन वी हैव दिस रैपिड ब्रीदिंग. सो सिचुएशन में बेस्ट वे इज स्लो एंड डीप ब्रीदिंग. Coming to the next one, difference in trajectory between inspiratory loop and expiratory loop in the curve is due to. This is the inspiratory loop, this is the expiratory loop. So option A, difference in alveolar pressure during inspiration and expiration. Option B, difference in concentration of surfactant during inspiration and expiration. Option C, difference in airway resistance during inspiration and expiration. Option D, inspiration is active, expiration is passive. Which of the following is going to explain this difference in trajectory? Because of concentration of surfactant. Very true. Hysteresis. This hysteresis is due to difference in compliance during inspiration and expiration, and that is due to this concentration of surfactant. क्या होता है at the start of inspiration अगर बात करेंगे तो alveoli are small and smaller alveoli में हमारा जो surfactant distribute होगा then area small है तो कंसंट्रेशन क्या हो जाएगा, मोर हो जाएगा, सरफेस टेंशन रिड्यूस हो जाएगा एंड सरफेस टेंशन रिड्यूस हो जाएगा तो कॉम्प्लायंस इज मोर. एट द एंड ऑफ इंस्पिरेशन एल्वेओलाई बिकम लार्जर, लार्जर एरिया में हमारा सर्फेक्टेंट डिस्ट्रीब्यूट होगा, कंसंट्रेशन ऑफ सर्फेक्टेंट इज गोइंग टू डिक्रीज, सो कॉम्प्लायंस इज गोइंग टू डिक्रीज क्योंकि surface tension क्या होगा, overall surface tension is more and we all know compliance is inversely proportional to the surface tension. Surface tension is more, so compliance is less. So that's why there is a compliance change during inspiration and expiration, because at the start of inspiration compliance is more, at the end of inspiration compliance is less, while at the start of expiration compliance is more less and at the end of expiration compliance is less, and this all is due to the concentration of surfactant. So answer is B only. Is this clear with everybody? Moving further, the normal compliance of lung is 20 ml per centimeter of water, 800 ml per centimeter of water, 500 ml per centimeter of water or 1000 ml per centimeter of water. Compliance of lung is, it is 200 ml per centimeter of water. Coming to the next one, tidal volume is calculated as inspiratory capacity minus inspiratory reserve volume, total lung capacity minus reserve volume, residual volume capacity minus FRC minus residual volume, vital capacity minus expiratory reserve volume. Which of the following statement is true? Tidal volume is calculated by, yeah, very true, inspiratory capacity minus inspiratory reserve volume, because inspiratory capacity is equal to inspiratory reserve volume plus tidal volume. So answer is A. Coming to the next one, volume of air that is taken in and taken out during normal respiration is referred as inspiratory reserve volume, tidal volume, expiratory reserve volume or the vital capacity. Yeah, it is our tidal volume, not expiratory reserve volume. Expiratory reserve volume क्या है, normal expiration के बाद जो हम deeply expire कर सकते हैं, that is expiratory reserve volume. Is this clear? So answer is only and only B. Coming to the next one, FRC is volume remaining after forced expiration, tidal volume plus volume inspired forcefully, volume remaining after normal expiration, tidal volume plus volume expired by forced expiration is FRC. Which of the following is true? No, it is not B. Tidal volume plus volume inspired forcefully, that is inspiratory reserve volume. So this is inspiratory reserve capacity, not the FRC. FRC क्या होता है? FRC is our expiratory reserve volume plus our residual volume. So this is the volume that is remaining in our lung after normal expiration. So answer is C. Coming to the next one, FRC is defined as volume expired after normal expiration, volume remaining after forced expiration, expiratory reserve volume plus residual volume, tidal volume plus volume inspired forcefully. Easy? FRC we just discussed किया था expiratory reserve volume plus residual volume. So answer is C. Coming to the next one. Total lung capacity depends upon size of airway, closing volume, lung compliance or the residual volume. Total lung capacity depends airway to depend upon lung compliance. Next question. Regarding pulmonary function test, all are true except total lung volume increases in emphysema, compliance decreases in interstitial lung disease, compliance is total lung distensibility, FEV1 is forced expiratory rate at 1 minute. Very true. FEV1 is forced expiratory rate in 1 second, not 1 minute. Next one. Which of the following is used to measure the resistance to small airway or best denote airway resistance? Option A, vital capacity. Option B, FEV1. Option C, maximum mid-respiratory flow rate. Option D, closing volume. Do you remember this is the maximum mid-respiratory flow rate? Yeah, way true, Dr. Sri, Dr. Shrujana. Answer is C. Maximum mid-respiratory flow rate bestly denote our airway resistance. Coming to the next one. Critical closing volume is option A, volume at the end of forceful expiration. Option B, volume at the end of forceful inspiration. Volume remaining after FRC is measured. Option D, close to residual volume. Critical closing volume is the volume remaining after FRC is measured. No, it's not to be. Volume at the end of forceful inspiration is our total lung capacity. Volume at the end of forceful expiration is our residual volume. After FRC जो हमारा जो volume lung में रहता है, that is our critical closing volume. That is the volume that is entrapped by the basal region of alveoli at the end of expiration. So answer is C. Coming to the next one. Pulmonary function abnormalities in interstitial lung disease include all of the following except reduced vital capacity, reduced Tiffany index, reduced diffusion capacity, reduced total lung capacity. Pulmonary functional abnormalities in interstitial lung disease include all of the following except. Everybody answer this question. देखो interstitial lung disease में क्या होता है? Compliance decreases, vital capacity decreases, diffusion capacity decreases, total lung capacity decreases, but the Tiffany index increases or remain normal. So answer is B. Coming to the next one, which set of data correctly define restrictive lung disorder? FRC increases, compliance increases, FEV1 upon forced vital capacity ratio increases, compliance decreases, FEV1 upon forced vital capacity ratio decreases, compliance decreases. Option D, total lung capacity increases, residual volume decreases. Answer this question. Which set of data correctly define the restrictive lung disorder? Tiffany index increases and our compliance decreases. So answer is B. Coming to the next one. In upper airway obstruction, all of the following are seen except decreased maximal breathing capacity, residual volume decreases, decreased FEV, decreased vital capacity. In upper airway obstruction, all are seen except residual volume decreases. No, residual volume not decreases in this situation. So answer is B. Coming to the next, pulmonary function changes seen in emphysema are total lung capacity increases, residual volume decreases, FEV1 increases, vital capacity increases. In emphysema, total lung capacity increases, FEV1 increases, vital capacity increases. So answer is A, C, D. Coming to the next one. In a body plethysmography, a person is asked to expire against a closed glottis. What will be the changes in the pressure at the level of lung and the box? Increases in both, decreases in both, increases in lung, decreases in box, decreases in lung, increases in box. In body plethysmography, when person is asked to expire, the volume in the lung is going to decrease, so pressure at the level of lung is going to increase. Box में क्या होगा? Volume is going to increase, so pressure at the level of box is going to decrease. So answer is C. Is this clear? Coming to the next question, vital capacity is summation of inspiratory reserve volume, tidal volume plus expiratory reserve volume. Vital capacity is tidal volume plus inspiratory reserve volume plus residual volume. Expiratory reserve volume, inspiratory reserve volume plus residual volume. Residual volume, inspiratory volume, expiratory volume. Vital capacity is a summation of. Vital capacity doesn't include the residual volume, so all are wrong. Only and only answer is false. Inspiratory reserve volume plus tidal volume plus expiratory reserve volume, it is going to see this vital capacity. Very true. Coming to the next, spirometry measures tidal volume, total lung capacity, expiratory reserve volume, FRC, inspiratory reserve volume. Which volume and capacity we can measure it from the spirometry? We can measure the tidal volume, we can measure this expiratory reserve volume, we can measure this inspiratory reserve volume. We cannot measure the total lung capacity, we cannot measure the FRC. Answer is only and only A, C and E. Coming to the next, spirometry can measure all of the following except tidal volume, residual volume, vital capacity or inspiratory reserve capacity. Spirometry can demonstrate and measure all of the following except spirometry can demonstrate, yeah, very true, it cannot measure the residual volume. So answer is B. Very true. Coming to the next one, nitrogen washout method is used for estimating dead space volume, FRC, tidal volume or diffusion capacity. Nitrogen washout method is used to measure our FRC. Dead space के लिए volume के लिए we use single nitrogen breathe method, not washout method. Do not confuse with this one. So answer is FRC. Is this clear? Coming to the next one. This given graph likely depict which of the following disease? This graph. Bronchial asthma, emphysema, interstitial lung disease or the normal study. First of all, ये graph क्या show कर रहा है? It is showing for given change in a pressure, the volume change is very low. ठीक है, pressure change कितना ज़्यादा है and volume change is low. So कैसा curve हो गया? Low compliance curve हो गया and low compliance is seen in anybody? It is seen in interstitial lung disorder, not in emphysema. Emphysema में compliance increase होता है. So answer is C. Is this clear, everybody? We are going to revise is first, that is diffusion and transport of gas. First, coming to the introduction part, inspired air contain more oxygen and less carbon dioxide. जबकि deoxygenated blood that is coming to lung for oxygenation is containing less oxygen and more carbon dioxide. So हम देख रहे हैं कि we are seeing this concentration gradient and we all know diffusion happen along the concentration gradient. From higher concentration, our gases move from higher concentration to lower concentration via the process of diffusion. And this diffusion required the respiratory membrane. Next important point is deoxygenated blood stay inside the vessel for 0.8 second. और इसी 0.8 second में क्या होगा? Diffusion will have to be happen. ठीक है, so this 0.8 second is important because इसी second में हमारा deoxygenated blood vessels में होता है. So now coming to the simple diffusion, क्योंकि हमारा जो भी gaseous exchange है that occurs by the simple diffusion. So now coming to this one. This is a passive process and this follows the Fick's law. What does Fick's law state? Diffusion is directly proportional to the concentration gradient. More the concentration gradient, higher will be the rate of diffusion. It is directly proportional to this area. More the surface area of the membrane, more will be the diffusion. It is inversely proportional to the thickness of membrane. जितना ज़्यादा thick membrane होगा, diffusion rate is least. Diffusion is directly proportional to the solubility. More the substance is lipid soluble, more will be the rate of diffusion. Diffusion is inversely proportional to the size of particle. जितना बड़ा साइज होगा डिफ्यूजन रेट क्या होगा, दैट इज गोइंग टू बी लेस। अब बात करेंगे हमारा डिफ्यूजन कब डिक्रीज होता है, एरिया डिक्रीज हो जाए या थिकनेस ऑफ मेम्ब्रेन इंक्रीज हो जाए। तो क्लिनिकल एस्पेक्ट की बात करेंगे तो एरिया इंक्रीजेस इन द एम्फाइसेमा। एम्फाइसेमा में क्या होता है, सरफेस एरिया डिक्रीज होता है। सरफेस एरिया डिक्रीज होता है तो क्या होगा, डिफ्यूजन रेट डिक्रीज होगा। थिकनेस, हमारा पल्मोनरी फिब्रोसिस में क्या होता है, मेम्ब्रेनल थिकनेस इंक्रीज होता है, सो दैट्स व्हाई डिफ्यूजन इज गोइंग टू डिक्रीज इन दिस सिचुएशन। इज दिस क्लियर विथ एवरीबॉडी? डू रिप्लाई फास्ट। दोनों क्लिनिकल एस्पेक्ट क्लियर है? Moving further, now coming to the diffusion measurement. How we measure this diffusion? Diffusion को measure करने के लिए we use this Delco test. That is diffusion capacity of lung for carbon monoxide. Why we are using this carbon monoxide? Because carbon monoxide has 210 times more affinity to hemoglobin as compared to oxygen. ठीक है, कार्बन मोनोऑक्साइड की एफिनिटी to the hemoglobin is 210 times more as compared to oxygen. That's why we are using this carbon monoxide to measure the diffusion capacity. Normal diffusion capacity of carbon monoxide is 25 ml per minute per mm of Hg. So how we measure this one? We measure this one by this formula. Delco is equal to carbon monoxide uptake in the blood upon partial pressure of carbon monoxide in the alveoli minus partial pressure of carbon monoxide in the blood. So this is going to give us this value of delco, that is normally it is 25 ml per minute per mm of Hg. और normal patient में we all know blood में carbon monoxide क्या होता है, zero होता है, so that's why this becomes zero. So normal patient में अगर बात करेंगे तो delco का formula क्या हो जाएगा, carbon monoxide uptake in the blood upon partial pressure of carbon monoxide in the alveoli. So this formula is important, do remember everybody. So now coming to the clinical aspect, there are some situations where diffusion capacity of lung for carbon monoxide decreases. There are some situations where diffusion capacity of lung for carbon monoxide is going to increase. अभी जस्ट बात किया था एम्फाइसेमा में क्या होता है, एम्फाइसेमा में एरिया डिक्रीज होता है, डिफ्यूजन कैपेसिटी डिक्रीजेस। पल्मोनरी फिब्रोसिस में क्या है, थिकनेस ऑफ मेम्ब्रेन इंक्रीजेस, सो द डिफ्यूजन decreases. So first is emphysema, second is pulmonary fibrosis, and next was anemia. Anemia में क्या है, RBC count is less, and RBC count less है तो सिचुएशन में हीमोग्लोबिन काउंट लेस है तो उस सिचुएशन में क्या होगा, डिफ्यूजन कैपेसिटी ऑब्वियसली इट गोइंग टू डिक्रीज। नेक्स्ट इज द सिचुएशन जहाँ पे हमारा डिफ्यूजन कैपेसिटी ऑफ लंग इंक्रीजेस, it is during the polycythemia. Polycythemia में RBC number is more, and since RBC number is more, hemoglobin will be more, and that's why the diffusion capacity of lung for carbon monoxide increases. Physiological situation like exercise, उस समय भी क्या होता है, हमारा relative polycythemia occurs, and that's why in that situation also diffusion capacity of lung for carbon monoxide increases. ठीक है, clear everybody? Moving further, this point is also important. Carbon dioxide is 20 times more soluble as compared to oxygen. Do you remember? ठीक है, अब बात करते हैं टॉपिक पे, दैट इज ट्रांसपोर्ट ऑफ गैस। इसमें ऑक्सीजन ट्रांसपोर्ट होगा, कार्बन डाइऑक्साइड ट्रांसपोर्ट होगा। फर्स्ट कमिंग टू दिस ऑक्सीजन ट्रांसपोर्ट। ऑक्सीजन क्या है, हमारा कंबाइन कर जाता है हीमोग्लोबिन से एंड इट फॉर्म ऑक्सी हीमोग्लोबिन, एंड 97% अगर बात करें ट्रांसपोर्ट की ऑक्सीजन की, दैट अगर इन द फॉर्म ऑफ ऑक्सी हीमोग्लोबिन। रेस्ट 3% जो हमारा ऑक्सीजन का ट्रांसपोर्ट होता है, दैट इज डिसॉल्व इन द प्लाज्मा। नेक्स्ट इज आर कार्बन डाइऑक्साइड ट्रांसपोर्ट। Carbon dioxide combined with the hemoglobin and form carb amino hemoglobin. Carbon dioxide plus hemoglobin, carb amino hemoglobin. Minor form of transport है. 30% around हमारा जो carbon dioxide का transport होता है that occur in the form of carb amino hemoglobin. And rest जो major part है that occur in the form of bicarbonates. ठीक है. तो 27% हमारा in the form of carb amino hemoglobin, 70% in the form of bicarbonate, and rest 3% is in the form of dissolved in the plasma. So this is about the carbon dioxide transport. अब इसी को डिटेल में देखते हैं. Now coming to the oxygen का क्या partial pressure होता है different level पे. तो environmental air की अगर बात करते हैं तो 21% ऑक्सीजन होता है. तो environmental air has a partial pressure of oxygen of 160 mm of Hg. ऑन इंस्पिरेशन क्या होगा, एयर हमारा लंग्स में आता है, लंग के एपिथेलियल से गेट ह्यूमिडिफाइड एंड तो ह्यूमिडिफिकेशन की वजह से एयर क्या होगा, डाइल्यूट होगा. सो पार्शियल प्रेशर ऑफ ऑक्सीजन डिक्रीजेस. सो पार्शियल प्रेशर ऑफ ऑक्सीजन डिक्रीजेस फ्रॉम 160 टू 150 mm of Hg. ठीक है. अब ये एयर हमारे एल्वेलाई में होएगा. एल्वेलाई में गैसियस एक्सचेंज होगा एंड एल्वेलाई में जो एयर का पार्शियल प्रेशर हो जाएगा ऑक्सीजन का दैट बिकम 104 mm of Hg. ठीक है. डू रिमेंबर डिफरेंट लेवल पे जो पार्शियल प्रेशर ऑफ ऑक्सीजन है दैट इज इंपॉर्टेंट फ्रॉम द एग्जाम पॉइंट ऑफ व्यू. नेक्स्ट बात करेंगे दैट इज द समरी. पार्शियल प्रेशर ऑफ ऑक्सीजन इन एनवायरमेंटल एयर इज 160 दैट इज corresponding to 21% of oxygen. Partial pressure of oxygen in inspired air is 150 mm of Hg. Partial pressure of oxygen in alveolar air is 104 mm of Hg. Partial pressure of oxygen in expired air is 120 and that corresponds to 16% of oxygen. इस पॉइंट पे काफी सारे क्वेश्चन आते हैं. डू रिमेंबर एवरीबडी. इन्वायरमेंटल एयर में हमारा 21% ऑक्सीजन होता है और expired air में we have this 16% of oxygen. So that's why when we are giving this mouth to mouth respiration we are providing 16% oxygen to the patient. ठीक है. आर्टेरियल ब्लड की में बात करेंगे तो आर्टेरियल ब्लड में पार्शियल प्रेशर ऑफ ऑक्सीजन इज 95 mm of Hg. पार्शियल प्रेशर ऑफ ऑक्सीजन इन वीनस ब्लड इज 40 mm of Hg. So all these points are very important. Do remember everybody. Moving further to the diagram, this is the partial pressure of oxygen in inspired air. On humidification हमारा decrease होगा, so it decreases to 150 mm of Hg. At the level of alveolar gaseous exchange होगा, it reaches to 104 mm of Hg. हमारा deoxygenated blood में partial pressure of oxygen कितना होता है 40 mm of Hg and हमारा oxygenated blood में it is approx 100 mm of Hg. और कार्बन डाइऑक्साइड की बात करेंगे तो पार्शियल प्रेशर ऑफ कार्बन डाइऑक्साइड इन डीऑक्सीजनेटेड ब्लड इज 46 एंड इन ऑक्सीजनेटेड ब्लड इट इज 40. एल्वेलस में भी कितना हो जाएगा, पार्शियल प्रेशर ऑफ कार्बन डाइऑक्साइड एट द लेवल ऑफ एल्वेलस इज आल्सो 40. इज दिस क्लियर विद एवरीबॉडी? डू यू रिप्लाई फर्स्ट? इज दिस क्लियर? So different level पे partial pressure of oxygen, partial pressure of carbon dioxide, do remember. Moving further to the detail of this oxygen transport in the blood. 90% हमारा किसके फॉर्म में होता है, ऑक्सी हीमोग्लोबिन के फॉर्म में होता है. एंड वी ऑल नो 1 ग्राम ऑफ हीमोग्लोबिन से कितना मॉलिक्यूल ऑफ ऑक्सीजन ट्रांसपोर्ट होता है, इट कैन ट्रांसपोर्ट 1.34 ml of oxygen. So 15 gram of hemoglobin will carry 20 ml of oxygen. So we can say our oxygen carrying transport of blood is 20 ml of oxygen per 100 ml of blood. ठीक है? Is this clear? सो ऑक्सी हीमोग्लोबिन के फॉर्म में मेजर ट्रांसपोर्ट है, माइनर ट्रांसपोर्ट क्या है, डिसॉल्व इन द फॉर्म ऑफ प्लाज्मा। अब जो प्लाज्मा में जो डिसॉल्व होगा ऑक्सीजन, दैट इज गोइंग टू डिटरमाइन द पार्शियल प्रेशर ऑफ ऑक्सीजन। किसी भी गैस का पार्शियल प्रेशर कब होगा, व्हेन इट इज डिसॉल्व इन प्लाज्मा, ठीक है। एंड डिसॉल्व के लिए जो डेटा है दैट इज 0.3 ml of oxygen dissolved in per deciliter of blood, and this formula is important. Dissolved oxygen content is equal to partial pressure of oxygen into solubility coefficient of oxygen, and solubility coefficient of oxygen कितना होता है, 0.003 ml per 100 ml per mm of Hg. Excuse me. This formula is important to remember. When dissolved oxygen content अगर निकालना हो तो it is equal to partial pressure of oxygen बताओ into solubility coefficient. Solubility coefficient of oxygen is 0.003 ml per 100 ml per mm of Hg. Moving further to the oxygen utilization coefficient. What do you mean by this oxygen utilization coefficient? 100 ml of blood is carrying 20 ml of oxygen, and जबकि इसमें से अगर टिश्यू की बात करें तो टिश्यू एक्सट्रैक्ट ओनली 5 ml. सो 20 ml का 5 ml यानी यूटिलाइजेशन कोफिशिएंट कितना हो गया, 25%. Is this clear with everyone? समझ में आया? ऑक्सीजन यूटिलाइजेशन कोफिशिएंट क्या है, 20 ml इज कैरिड बाय ब्लड, 100 ml ऑफ ब्लड, और टिश्यू कितना एक्सट्रैक्ट कर रहा है, इट इज एक्सट्रैक्टिंग ओनली 5%. तो यूटिलाइज कितना हो रहा है, ओनली 25%. सो यूटिलाइजेशन कोफिशिएंट ऑफ ऑक्सीजन इज ओनली 25%. या और यू कैन सी आर्टेरियो वीनस ऑक्सीजन डिफरेंस इज 25%. ठीक है, क्लियर? So moving further, this arteriovenous oxygen difference is highest in the heart. Means heart extract more oxygen from our blood. Approx 75% of oxygen is extracted from our heart, by our heart. Oxygen extraction by the kidney is lowest. It is only 10%. So do remember this oxygen utilization coefficient, the arteriovenous difference is highest in our heart, 75%, and it is lowest in our kidney, that is 10% only. So now coming to the next point, that is respiratory exchange ratio. What do you mean by this respiratory exchange ratio? Respiratory exchange ratio is volume of carbon dioxide produced or volume of oxygen used. This is our respiratory exchange ratio. Volume of carbon dioxide produced upon volume of oxygen used. This is respiratory exchange ratio. और स्टीडी कंडीशन में अगर बात करेंगे, it is also known as the respiratory quotient. ठीक है, this respiratory quotient for patient having mixed diet is 0.8. For carbohydrate diet, patient having carbohydrate diet, the respiratory quotient is 1. Patient having fat rich diet, the respiratory quotient is 0.72. प्रोटीन रिच डाइट अगर पेशेंट ले रहा है तो उस सिचुएशन में रेस्पिरेटरी क्वेश्चन इज 0.8. मूविंग फर्दर टू द नेक्स्ट इंपॉर्टेंट टॉपिक ऑफ टुडेज सेशन, दैट इज ओडीसी कर्व, ऑक्सीजन हीमोग्लोबिन डिसोसिएशन कर्व. बिल्कुल एक क्वेश्चन बिल्कुल फॉर श्योर रहता है हमारे एग्जामिनेशन में मोस्ट ऑफ द केसेस में. सो ऑक्सीजन डिसोसिएशन कर्व के लिए फर्स्ट इंपॉर्टेंट पॉइंट, द शेप ऑफ दिस कर्व इज सिग्मोइड. Partial pressure of oxygen 100 mm of Hg क्या है, plateau phase is reached, and partial pressure of oxygen 27 mm of Hg क्या होता है, 50% saturation. मीन्स 100% saturation कब होगा 100 mm of Hg पे 50% saturation of hemoglobin occur at 27 mm of Hg. So that's why this 27 mm of Hg is known as P50, means partial pressure at which 50% saturation of hemoglobin occurs is 27 mm of Hg. This is for our hemoglobin. अगर myoglobin की बात करते हैं तो P50 for the myoglobin is 5 mm of Hg, and that's why the shape of ODC curve for myoglobin is the rectangular hyperbola. ठीक है, हमारा हीमोग्लोबिन के लिए शेप कैसा है सिग्मोइड. P50 कितना है 27. For myoglobin it is 5 mm of Hg and shape is rectangular hyperbola. So see, this is the diagram showing our 100 mm of Hg पे we are getting this plateau phase which is indicating 100% oxygen saturation. ठीक है, 100 mm of Hg पे we are getting this plateau phase which is indicating our 100% saturation. At 27 mm of Hg we are getting this 50% saturation of hemoglobin. So that's why it is known as P50. Shape कैसा है? It is sigmoid in shape. Moving further to the myoglobin. Myoglobin में P50 is 5 mm of Hg. So that's why this is the 50% saturation of myoglobin, and it is 5 mm of Hg. So that's why the shape is a rectangular hyperbola. Moving further, we all know one molecule of hemoglobin से कितना molecule of oxygen combined होता है 4 molecule of oxygen binds with the 1 molecule of hemoglobin. So normally क्या होता है जब first molecule of oxygen bind करता है hemoglobin से तो there is breakage of some salt bridges, and salt bridges break होगा, rest 3 oxygen molecule easily bind up कर जाता है hemoglobin से, and this phenomena is known as the theory of cooperativity. What does this theory of cooperativity states? कि first molecule of oxygen bind tightly with the hemoglobin, due to that breakage of some salt bridges occur, and rest 3 molecule bind with ease, and this is the cause of sigmoidal shape of ODC curve. ठीक है, तो do remember this one. Theory of cooperativity की वजह से there is sigmoid shape of ODC curve. Now moving to the important point, that is shifting of this ODC curve. The ODC curve can either shift to right, which is also known as Bose effect. This ODC curve can either shift to left, which is also known as Halden effect. First, coming to the right shift of ODC curve. Let me draw the curve for all of you. This is the normal ODC curve, which is sigmoidal in shape. Now coming to the right shift. This is the right shift curve, which is also known as Boyle's effect. So what we all are seeing in this situation, this is the 50% saturation. So this is the P50 of normal curve. This is the P50 of shifted curve. So what we all are seeing out here, that P50 out here is increased. P50 इंक्रीज हो रहा है, मीन्स हायर प्रेशर पे हमारा 50% सैचुरेशन हो रहा है, तो एफिनिटी ऑफ हीमोग्लोबिन क्या हो गया, एफिनिटी ऑब्वियसली डिक्रीज हुआ होगा, तभी हायर प्रेशर पे हमारा 50% सैचुरेशन हो रहा है. सो एफिनिटी डिक्रीज, एफिनिटी जब डिक्रीज होगा तो ऑक्सीजन क्या होगा, ऑक्सीजन विल बी रिलीज्ड फ्रॉम हिम, and this release of oxygen occur at the level of tissue. So all these 4 points is important. Now coming to the causes of this right shift, hypoxia causes this right shift, hypercarbia is going to cause this right shift, carbon dioxide more hoga, obviously carbonic acid will be more, so acidosis situation will also cause this right shift of ODC curve. Next is 2,3 diphosphoglycerate. क्या होगा, during hypoxia एनारोबिक ग्लाइकोलाइसिस होगा हमारी बॉडी में. एनारोबिक ग्लाइकोलाइसिस का इंटरमीडिएट प्रोडक्ट बनता है 2,3-डाइफॉस्फोग्लिसरेट. सो उस सिचुएशन में भी हमारा ओडीसी कर्व विल शिफ्ट टुवर्ड्स राइट. हाई एल्टीट्यूड की अगर बात करें तो हाई एल्टीट्यूड में भी प्रोलॉन्ग हाइपोक्सिया है, दैट इज गोइंग टू कॉज दिस राइट शिफ्ट. एक्सरसाइज में भी क्या होगा, ऑक्सीजन रिक्वायरमेंट हमारी बॉडी का इंक्रीज होता है. सो टू रिलीज ऑक्सीजन आवर ओडीसी कर्व विल शिफ्ट टुवर्ड्स राइट. Same situation, hypothermia, oxygen requirement is more, so ODC curve will shift towards right. So right shift of ODC curve is known as Bose effect. Is this clear with everybody? So right shift कब हो रहा है? It is occurring in the situation of hypoxia, hypocarbia, acidosis, 2,3-diphosphoglycerate, high altitude exercise, and the hypothermia. Is this clear with everybody? Do reply fast. किसी को भी कोई डाउट है तो क्लियर कर सकते हैं. एवरीबडी इज दिस क्लियर? राइट शिफ्ट के बाद वी आर गोइंग टू डिस्कस द लेफ्ट शिफ्ट. अगर राइट शिफ्ट क्लियर है तो गिव मी थम्स अप. So moving further to the left shift. Left shift of ODC curve is also known as Haldane effect. To understand this one, let me draw the curve for all of you. This is the normal OHDC curve, and this is during the left shift. So now coming to the P50, and this is the 50% saturation. So this is the 50% saturation for normal curve, and this is the 50% saturation for left shift curve. So for left shift we are seeing this P50 is decrease, means lower pressure पे हमारा 50% saturation occurred. So means affinity of a hemoglobin towards oxygen is increase. So lower pressure पे इसीलिए हमारा 50% saturation हो गया. So affinity is increased, so we can say this there will be loading of oxygen. Affinity increase हुआ है तो oxygen will be loaded, and this loading occur at the level of lung. So left shift occur at the level of lung. Is this clear? Now coming to the causes of left shift. Left shift occur in hypocarbia, alkalosis, fetal hemoglobin. Why in fetal hemoglobin? क्योंकि fetal hemoglobin की affinity toward oxygen is more, and its affinity towards 2,3-diphosphoglycerate is less. So fetal hemoglobin में भी क्या होगा? ODC curve will shift towards stored blood. Stored blood में क्या होगा? Glycolysis will not be there. So 2,3-diphosphoglycerate क्या होगा? Less होगा. तो उस सिचुएशन में OHDC curve will shift towards left. ठीक है. हाइपोथर्मिया, हाइपोथर्मिया में भी OHDC कर्व कहाँ शिफ्ट करता है? It shift towards left. Is this clear with everybody? So this is the summary. Right shift is also known as, जल्दी जल्दी रिप्लाई करो. Right shift is also known as Bose effect. Left shift is also known as Haldane effect. Right shift में what happens to P50? P50 in right shift increases, means affinity is going to decrease, and affinity decrease होगा, there will be release of oxygen, and this release of oxygen occur at the level of tissue. So this right shift or Bose effect occur at the level of tissue. ठीक है? Is this clear? Haldane effect की बात करेंगे तो Haldane effect में P50 decreases, means affinity is going to increase. So since affinity is increased, तो ऑक्सीजन क्या होगा, there will be loading of oxygen, and since there is a loading of oxygen, this occur at the level of lungs. Is this clear with everyone? Moving further to the carbon dioxide transport. Major जो transport है that occur in the form of bicarbonate. Mass 70% transport in the form of bicarbonate, 30% when combined with 27% when combined with the hemoglobin, it form carb aminohemoglobin, and 3% dissolve in the plasma. ठीक है, तो हमारा जो 70% कार्बन डाइऑक्साइड है that react with the water molecule and it is going to form this carbonic acid in the presence of carbonic anhydrase. This enzyme is most abundantly found in our RBC. और कार्बोनिक एसिड जैसे ही फॉर्म करेगा it is going to dissociate to form H plus ion and the bicarbonate ion. This bicarbonate ion move from the RBC via this bicarbonate chloride exchanger. And in exchange क्या होगा, chloride ion move inside the RBC. ठीक है, this chloride ion is osmotically active, so it is bringing water molecule along with itself. So that's why what happened, RBC will become swollen. ठीक है, और जो हाइड्रोजन आयन बना that is going to be buffered with the hemoglobin. Hemoglobin इसको buffer कर देगा. This bicarbonate is going to reach outside and in exchange chloride ion move inside the RBC, and RBC में हमारा along with the chloride ion water ion also move because it is osmotically active substance. So that's why RBC becomes swollen, and this exchange of bicarbonate and chloride ion is also known as Hamburger's phenomena, chloride shift or Hamburger's phenomena. Is this clear with everybody? See, same thing is written out here. Channel protein involved out here is bicarbonate chloride exchanger. Exchanger है, so it is a classical example of secondary active transport. Or you can say this is an ion exchanger. So for every bicarbonate ion moving outside the RBC, one chloride ion move inside the RBC to maintain the electroneutrality, and this is known as the chloride shift or Hamburger's phenomena. ठीक है, H plus ion क्या होगा, H plus ion in the RBC will be buffered by hemoglobin. Is this clear with everybody? This is about bicarbonate exchange. So chloride ion is osmotically active substance, so it brings water molecule along with it. So RBC becomes swollen. So that's why packed cell volume of a venous blood is more. Because of this swollen RBC, packed cell volume venous blood का क्या होगा, that is going to be increased. ठीक है, this point is also important from the exam point of view to remember everybody. ठीक है, अभी तक सेशन में किसी को कोई डाउट, anybody, any query till now you can ask in the session only. समझ में आ रहा है सेशन? Everybody do reply fast. चलो, moving further to the next, that is carbon dioxide dissociation. Venous partial pressure of carbon dioxide कितना होता है, 45 mm of Hg. So ये हमने y axis पे क्या लिया है, carbon dioxide in blood, and x axis पे क्या लिया है, gas pressure of carbon dioxide. So at 45 mm of Hg, this is the 45 mm of Hg. उस समय अगर कार्बन डाइऑक्साइड कंसंट्रेशन इन ब्लड की बात करेंगे, सो इट इज 52. एट 45 mm of Hg कार्बन डाइऑक्साइड का कंटेंट कितना होता है ब्लड में, दैट इज 42 ml पर 52 ml कार्बन डाइऑक्साइड पर डेसीलीटर ऑफ ब्लड. ठीक है। 40 mm ऑफ Hg हमारा आर्टीरियल ब्लड में कार्बन डाइऑक्साइड का कंसंट्रेशन होता है। सो उस पे हमारा जो कार्बन डाइऑक्साइड कंटेंट होगा उस समय हमारे ब्लड में, दैट इज 48 ml पर डेसीलीटर ऑफ ब्लड। सो दिस टू डाटा इज इम्पॉर्टेंट एंड इससे हम कह सकते हैं, वी कैन से दिस वन, दिस दैट इज 4 ml ऑफ कार्बन डाइऑक्साइड इज ट्रांसपोर्टेड। ठीक है, वीनस ब्लड से हमारा आर्टीरियल ब्लड में कितना डिफरेंस आया, 4 ml का। So we can say this 4 ml of carbon dioxide is transported at the level of lungs. Now coming to the next topic, this is also important one, that is ventilation and perfusion. So now coming to the first of all, what is the ventilation, what is the perfusion? Introduction part पे आ जाते हैं। Ventilation, the air in the lung is known as ventilation and this tidal volume is our ventilation. What is perfusion? The deoxygenated blood that is reaching to our lungs for oxygenation is known as our perfusion. ठीक है, तो वेंटिलेशन क्या हो गया, वेंटिलेशन आर टाइडल वॉल्यूम। अब इसमें एनवायरमेंटल एयर का कंपोजिशन की बात करेंगे तो नाइट्रोजन कंटेंट इन आवर एनवायरमेंटल एयर इज 79%, दैट इज मैक्सिमम वन। ऑक्सीजन कंटेंट कितना होता है, 21%, एंड कार्बन डाइऑक्साइड इन आवर एनवायरमेंटल एयर इज नील, इट इज 0। ठीक है, और एनवायरमेंटल एयर के पार्शियल प्रेशर की बात करेंगे तो इट इज 760 mm ऑफ Hg। नाउ कमिंग टू द पार्शियल प्रेशर, व्हाट इज पार्शियल प्रेशर? एक इंडिविजुअल गैस कितना प्रेशर एक्सर्ट कर रहा है अमॉन्ग द ग्रुप इज नोन एज पार्शियल प्रेशर। सो फर्स्ट कमिंग टू द पार्शियल प्रेशर ऑफ ऑक्सीजन, ऑक्सीजन का कंटेंट कितना होता है एनवायरमेंटल एयर में, इट इज 21%। सो 760 mm हमारा टोटल प्रेशर है, उसका 21% इज कंट्रीब्यूटेड बाय ऑक्सीजन, सो इट इज 160 mm ऑफ Hg। सो पार्शियल प्रेशर ऑफ ऑक्सीजन इज 160 mm of Hg in our environmental air. So हमारा 21% जो ऑक्सीजन प्रेजेंट है एनवायरमेंटल एयर में, दैट इज नोन एज फ्रैक्शनल कंसंट्रेशन ऑफ ऑक्सीजन इन आवर एनवायरमेंट। सो इट इज 21%, FiO2 को हम कह सकते हैं इट इज 0.21। ठीक है, इज दिस क्लियर? सो नेक्स्ट सेम थिंग इज रिटन आउट एनवायरमेंटल एयर में पार्शियल प्रेशर ऑफ ऑक्सीजन 160, ह्यूमिडिफिकेशन की बात हो जाएगा 150, गैसियस एक्सचेंज के बाद एल्वियोलस के लेवल पे 104 mm ऑफ Hg। सो नाउ कमिंग टू द नेक्स्ट टॉपिक, दैट इज एल्वियोलर गैस इक्वेशन। ठीक है, alveolar gas equation से we calculate how this partial pressure of oxygen at the level of alveolus is 104 mm of Hg। ठीक है, so this is the formula, partial pressure of oxygen at the level of alveolus is equal to partial pressure of oxygen in the inspired air minus partial pressure of carbon dioxide at the level of alveolus upon respiratory exchange ratio। अभी जस्ट पढ़ा था हमने, रेस्पिरेटरी एक्सचेंज रेशियो क्या होता है, वॉल्यूम ऑफ कार्बन डाइऑक्साइड प्रोड्यूस अपॉन वॉल्यूम ऑफ ऑक्सीजन यूज। सो इसको यूज करेंगे एंड वी कैन गेट दिस पार्शियल प्रेशर ऑफ ऑक्सीजन एट द लेवल ऑफ alveoli। We all know the respiratory exchange ratio in the normal situation having patient having mixed diet is 0.8। ठीक है, this formula is also important, partial pressure of oxygen in inspired air is equal to fractional concentration of oxygen into barometric pressure minus water vapor pressure। ठीक है, ये फॉर्मूला भी बिल्कुल याद रखिएगा, पार्शियल प्रेशर ऑफ ऑक्सीजन इन इंस्पायर्ड एयर इज इक्वल टू फ्रैक्शनल कंसंट्रेशन ऑफ ऑक्सीजन इनटू पार्शियल प्रेशर ऑफ barometric pressure minus water vapor pressure। So barometric pressure is 760, water vapor pressure is 47 mm। ठीक है, दिस इज द समरी। एनवायरमेंटल एयर में ऑक्सीजन का पार्शियल प्रेशर कितना होता है, 160। इंस्पायर्ड एयर में ह्यूमिडिफिकेशन की वजह से इट बिकम 150। एल्वेलर एयर में इट इज गोइंग टू डिक्रीज एंड इट डिक्रीजेस टू 104 and expired air it is 120 mm of Hg which corresponds to 16% of oxygen। means in mouth to mouth respiration we are providing this expired air, so we are providing the 16% oxygen to the patient. Now coming to the next, that is minute ventilation. What do you mean by this minute ventilation? Tidal volume into respiratory rate give us this minute ventilation. Tidal volume कितना होता है 500 ml. Respiratory rate कितना होता है 12. So normal tidal volume minute ventilation is 6 liter per minute. ठीक है, मिनट वेंटिलेशन कितना होता है 6 लीटर पर मिनट. अब टाइडल वॉल्यूम हम वी ऑल नो एक्सक्यूज मी, इट इज 500 ml. इस टाइडल वॉल्यूम का 150 ml गोज टू द डेड स्पेस वेंटिलेशन. मीन्स यहाँ पे वेंटिलेशन जो होगा वो वेस्टेड होगा, नो गैसियस एक्सचेंज. ओनली एंड ओनली 350 ml इज participating in the alveolar ventilation. So useful ventilation कितना हो गया only 350 ml. 150 ml क्या होता है useless होता है, no gaseous exchange occur. ठीक है, this dead space ventilation is in our conducting airway. पढ़ा है ना, conducting airway and exchange airway according to the Weibel's model. So the air that is present in our conducting airway is 150 ml, which is corresponding to the useless ventilation, which is not going to involve in the gaseous exchange. So useful ventilation की अगर बात करें तो हमारा सिर्फ 350 ml है. So first formula was minute ventilation, next is the alveolar ventilation. ठीक है, alveolar ventilation क्या हो जाएगा tidal volume into respiratory rate. So normal minute ventilation 6 liter per minute का होता है, normal alveolar ventilation कितना हो जाएगा 4 liter per minute. Is this clear everybody? अब फर्स्टली हम इसको बात कर लेते हैं डेड स्पेस वेंटिलेशन जो 150 ml है उसके बारे में. सो डिफरेंट टाइप ऑफ डेड स्पेस वेंटिलेशन आर देयर, एनाटॉमिकल डेड स्पेस, alveolar dead space and the physiological or total dead space. ठीक है, this physiological or total dead space तो derived one है. First coming to the anatomical dead space. तो हमारा वीबल मॉडल के अकॉर्डिंग जो कंडक्टिंग एयरवे है दैट इज फर्स्ट 16 जनरेशन ऑफ वीबल मॉडल इज आर कंडक्टिंग एयरवे एंड दैट कॉरेस्पॉन्ड्स टू दिस एनाटॉमिकल डेड स्पेस ऑफ 150 ml. ठीक है, और हेल्दी इंडिविजुअल में अगर हम एल्वेओलर डेड स्पेस की बात करते हैं तो इट इज 0. इट इज ऑलवेज एंड ऑलवेज प्रेजेंट इन सम पैथोलॉजिकल कंडीशन ओनली. इज दिस क्लियर? Next is the physiological or total dead space. Physiological or total dead space is equal to anatomical dead space plus alveolar dead space. So healthy individual की अगर बात करेंगे तो हमारा alveolar dead space is 0. So this anatomical dead space is equal to physiological dead space in a normal healthy individual. Is this clear with everybody? अब बात करते हैं how this dead space is measured. Anatomical dead space measure करने के लिए we use this Fowler's method, which is also known as single nitrogen breath method. Next is the physiological dead space. Physiological dead space को we use this Bose method. Bose method क्या है? Physiological dead space is equal to tidal volume into partial pressure of carbon dioxide in the alveolar air minus partial pressure of carbon dioxide in the expired air upon partial pressure of carbon dioxide in the alveolar air. This formula gives us this physiological dead space. Is this clear with everybody? So physiological dead space is equal to tidal volume, and physiological dead space upon tidal volume ratio क्या हो जाएगा? Partial pressure of carbon dioxide at the level of alveolus minus partial pressure of carbon dioxide in the expired air upon partial pressure of carbon dioxide in the alveolar air. This formula gives us this ratio, dead space upon tidal volume ratio. ठीक है, इस रेशियो में हमारा डेड स्पेस कितना है 150 ml, tidal volume कितना है 500 ml. So this ratio is 30%. Is this clear everyone? Same thing जो अभी हमने बात की थी alveolar ventilation. तो यूजफुल वेंटिलेशन हमारा कितना है 350 ml. So 350 ml into respiratory rate gives us this alveolar ventilation and it is 4 liter per minute. So we have two terms, alveolar ventilation and minute ventilation. Is this clear? दोनों में difference याद रहेगा? Everybody, minute ventilation is our tidal volume into respiratory rate. So it is 6 liter per minute. जबकि alveolar ventilation की अगर बात करेंगे तो it is 4 liter per minute only. ठीक है, everybody is this clear? किसी को भी कोई डाउट है तो क्लियर कर सकते हैं. Anybody, any query? Do reply fast. किसी को भी कोई डाउट है सेशन में तो क्लियर कर सकते हैं. एनीबडी, एनी क्वेरी? चलो फिर फर्दर मूव करते हैं. Now coming to the zones of ventilation. In lungs, we have 3 zones according to the ventilation in our lungs. That is zone 1, zone 2 and zone 3. First coming to the zone 1. Zone 1, this is present at the apex of lung, and apex of lung में we are seeing the alveolar sizes more. So there is increase in size of alveoli. So that's why क्या है इसमें compliance जब alveoli large होती है compliance is less. Compliance less है, stretching ability is less. So that's why ventilation at the apex of lung is minimum. It is 1.92 liter per minute. और zone 2 that is present at the middle lobe. Middle lobe में क्या है intermittent size of alveoli है. तो यहाँ पे ventilation भी intermittent होगा, that is 4 liter per minute. Zone 3 that is present at the base of lung, and at the base of lung we are seeing alveoli size are small. So smaller alveoli has better compliance. Its stretching abilities, and that's why ventilation at the base of lung is more. It is 6.5 liter per minute. So these are different 3 zones in our ventilation. Is this clear? So now coming to the perfusion. Perfusion already discussed. It is the pulmonary circulation that is reaching to our lung for its oxygenation is known as perfusion. So हमारा जो entire output, cardiac output है, that goes to the lung for oxygenation. So normal pulmonary circulation per minute की बात करेंगे तो it is 5 liter per minute. Perfusion के लिए pulmonary circulation involved है. So we are having 3 components of this perfusion: pulmonary artery, pulmonary capillary and pulmonary vein. Pulmonary artery is carrying the deoxygenated blood to the lung. The oxygenated blood reaches to heart via this vein, and capillary is the level जहाँ पे oxygenation occurs. So we have 3 components of our perfusion: pulmonary artery, pulmonary capillary and the pulmonary vein. Moving further, our pulmonary circulation is high compliant circulation. What do you mean by this high compliant circulation? अगर सिस्टमिक सर्कुलेशन से कंपेयर करेंगे पल्मोनरी वेसल्स की तो दैट इज 25% मोर, 24% मोर कॉम्प्लायंट होता है. मीन्स दे आर मोर स्ट्रेचेबल एज कंपेयर टू सिस्टमिक पार्ट. सो दे कैन स्ट्रेच एंड दे कैन accommodate large amount of blood. So that's why lung is also known as a reservoir of blood. 15 to 18% of total blood is always and always present in our lung. ठीक है. Pulmonary circulation is high compliant circulation. Pulmonary vessels are 24% more compliant as compared to the systemic counterpart. they can accommodate large amount of blood. 15 to 18% हमेशा हमारे lungs में present होता है. Is this clear? So now coming to the next important point, that is zones of perfusion in our lung. So why there are different zones in our lungs for the perfusion? Because of interplay of this alveolar pressure and the hydrostatic pressure. कैसे interplay होता है? First coming to the zone 1. The zone 1 is present at the apex of lung. And apex of lung की अगर बात करेंगे तो alveolar pressure is more as compared to arterial pressure. Arterial pressure is more as compared to the venous pressure. So alveolar pressure सबसे ज़्यादा है, so it is going to compress the artery as well as vein. So that's why there is no perfusion in zone 1. ठीक है? No blood flow. Alveolar pressure is maximum, artery and vein get compressed, so there is no blood flow in zone 1. Middle lobe में we have this zone 2. Zone 2 में pressure की बात करेंगे तो arterial pressure is more as compared to the alveolar pressure, but out here also the venous pressure is less as compared to the alveolar pressure. So arterial pressure हमारा ज़्यादा है, so artery compress नहीं होगी, only and only vein will be compressed. So इस situation में we are getting this pulsatile blood flow, which is also known as waterfall effect. So zone 1 में there is no blood flow, zone 2 में we have this pulsatile water flow. Last one, that is zone 3. This is present at the base of lung, and at the base of lung क्या होगा? हमारा arterial pressure is more than the venous pressure, and venous pressure is more than the alveolar pressure. ठीक है, सबसे ज़्यादा क्या होगा? हमारा alveolar pressure है. Alveolar pressure सबसे ज़्यादा है, so that's why हमारा ना artery compress है ना vein compress है, so there will be continuous blood flow. Blood flow is maximum in zone 3. Is this clear? Zone 1 में there is no blood flow, zone 2 में we have the pulsatile blood flow, in zone 3 the blood flow is maximum. Upright posture में अगर बात करते हैं तो in upright posture all these three zones are present in our lung. While in supine posture की बात करेंगे तो only and only zone 3 is present throughout the lung. Do remember this one. These all zones are present in upright posture only. Supine posture में we have only the zone 3 in our throughout lung. Next point. This is the diagram. This is the zone 1 which is present at the apex of lung, and at the apex of lung सबसे ज़्यादा क्या होता है? Alveolar pressure होता है. So artery get compressed, vein get compressed, so there is no blood flow. And zone 2 क्या होगा? Arterial pressure is more as compared to the alveolar pressure. So artery हमारी compressed नहीं होगी, only and only vein is compressed. So there is pulsatile or waterfall effect. Last one, that is zone 3, that is present at the base of lung, and at the base of lung हमारा सबसे least होता है alveolar pressure. So artery भी compress नहीं होगी, vein भी compress नहीं होगा. So there is a continuous blood flow in zone 3. So this is about the perfusion. Next important point है assisted ventilation. Assisted ventilation की किस situation में क्या हो गया? हमारा partial pressure of alveolus is increased. So zone 2 is converted, zone 3 is converted into zone 2, and zone 2 is converted into zone 1. Is this clear? Next important point. Hypoxia, most of the organs में क्या करता है? Vasodilate करता है. But hypoxia in lung causes vasoconstriction. Why is it so? See, hypoxia in other organ causes the vasodilation, while in lung it causes vasoconstriction. Why is it so? Because our lung consists of oxygen sensitive potassium channel. ठीक है? And whenever there is a hypoxia, this channel gets closed, and due to the closure of this channel, potassium efflux क्या हो जाएगा? Stop हो जाएगा. Potassium ion is going to accumulate inside the cell. Since positive ion is accumulating inside the cell, तो membrane क्या होगा? Depolarize होगा. जैसे ही potential हमारा -40 millivolt पे पहुंचेगा, तो this calcium channel open up. Calcium channel open होगा, calcium influx will start, and that is going to cause the contraction of cell. and that is responsible for the vasoconstricting action in the lung. Now coming to the significance, क्या significance है hypoxia induced vasoconstriction in lung? तो blood flow is directed toward a better ventilated alveoli. लोअर वेंटिलेटेड पुअरली वेंटिलेटेड एल्वेओलाई में क्या होगा, वेजो कंस्ट्रिक्ट हो जाएगा, ब्लड फ्लो रीडायरेक्ट होगा टुवर्ड्स द बेटर वेंटिलेटेड एल्वेओलाई. इज दिस क्लियर? मूविंग फर्दर to the next, that is the ventilation perfusion ratio. Ventilation is our alveolar ventilation. ठीक है, alveolar ventilation कितना होता है? Anybody अभी just discuss किया था. Alveolar ventilation is 4 liter per minute. Minute ventilation was 6 liter. Alveolar ventilation was 4 liter. Perfusion की बात करेंगे तो perfusion is our pulmonary circulation. So pulmonary circulation में कितना आता है? Our entire cardiac output, that is 5 liter per minute, reaches to our pulmonary circulation. So this ventilation perfusion ratio 4/5. So this is 0.8 in the normal situation. So ventilation perfusion ratio is 0.8 in the normal situation, and this normal ventilation perfusion ratio is seen only and only in the middle lobe of lung, middle region of lung. Do remember this point. This normal ventilation perfusion ratio is only and only present in the middle region of lung. So now coming to the apex. Apex पे क्या है हमारा? perfusion less है. Ventilation is less but perfusion is very less. Almost nil है perfusion. So this ratio increases, and at the apex हमारा ventilation perfusion ratio highest होता है, and it is 3.2. Base of lung की बात करेंगे तो perfusion ventilation is more, but perfusion is very more. So that's why the ratio is less at the base of lung. So at the base of lung, so at the base of lung की बात करेंगे तो ventilation perfusion ratio is 0.6, and at the apex of lung it is highest, it is 3.2. This is important from the exam point of view to remember this one. Moving further, now coming to the ventilation perfusion mismatch. First situation, ventilation perfusion is infinite. कोई भी ratio कब infinite होगा? When denominator is 0. ठीक है, so means ventilation is there but perfusion is not there. ठीक है, means perfusion ही है यानी blood flow is not there. So in this situation क्या है? Ventilation is there but there is no perfusion. So इस समय जो ventilation है वो क्या होगा? Wasted हो जाएगा. So ये कैसा हो गया? Wasted ventilation, जहाँ पे कोई gaseous exchange नहीं है. Because perfusion ही नहीं है तो gaseous exchange की बात ही नहीं आएगी. So first is ventilation perfusion ratio infinite, और same diagram है, यहाँ पे blood flow is not there but ventilation is there. So this ventilation is wasted ventilation, and normally अगर बात करें तो it is present in our physiological dead space. 150 ml हमारा physiological dead space होता है ना, वहाँ पे क्या है? Ventilation is there but there is no perfusion, so that is wasted ventilation. और सिचुएशन में क्या होगा? वेंटिलेशन परफ्यूजन रेशियो इज इनफाइनाइट. अगर पैथोलॉजिकल कंडीशन की बात करते हैं तो पल्मोनरी एम्बोलिज्म होगा. पल्मोनरी एम्बोलिज्म की वजह से क्या होगा? आर्टरी, हमारी पल्मोनरी आर्टरी क्या होगी? ब्लॉक्ड हो जाएगी, ब्लड फ्लो इज नॉट देयर, एंड इस सिचुएशन में क्या होगा? वेंटिलेशन इज देयर बट परफ्यूजन इज नॉट देयर. सो दिस रेशियो इज इनफाइनाइट. First situation clear है everybody? Ventilation perfusion ratio is infinite. Next one, this ventilation perfusion ratio is 0. Means ventilation is not there but there is perfusion. ठीक है, तो इस सिचुएशन में क्या होगा? Ventilation is not there but there is perfusion. Perfusion is there but there is no ventilation. So ये perfusion क्या हो जाएगा? Waste हो जाएगा. So we can say this perfusion is wasted perfusion or shunted perfusion. Means यहाँ पे भी कोई gaseous exchange नहीं होगा क्योंकि ventilation ही नहीं है. ठीक है, अगर एग्जाम्पल की बात करें तो नॉर्मली 2% ऑफ कार्डियक आउटपुट ऑलवेज एंड ऑलवेज गो इनटू दिस शंट परफ्यूजन. पैथोलॉजिकल बात करें तो अगर हमारे रेस्पिरेटरी ट्रैक में फॉरेन बॉडी ऑब्स्ट्रक्शन है तो एयरवे बिलो द ऑब्स्ट्रक्शन आर गोइंग टू बी कोलैप्स्ड. सो देयर इज नो वेंटिलेशन बिलो दैट ऑब्स्ट्रक्शन. सो उस सिचुएशन में क्या होगा? वेंटिलेशन परफ्यूजन रेशियो इज 0. सी दिस इज द डायग्राम. सपोज दिस इज आर obstruction. तो यहाँ पे क्या होगा? There will be no ventilation, only and only ventilate perfusion is there. So इस situation में perfusion क्या हो जाएगा? Waste हो जाएगा और shunt हो जाएगा. Is this clear? So ventilation perfusion infinite. Next is ventilation perfusion ratio is 0. ठीक है? Next situation. आ जाते हैं हम अपने डायग्राम पे. वेंटिलेशन परफ्यूजन डायग्राम विच इज आल्सो नोन एज ऑक्सीजन कार्बन डाइऑक्साइड डायग्राम. तो अभी जस्ट हमने बात की थी वेंटिलेशन परफ्यूजन इनफाइनाइट. ये कहाँ होता है? हमारे फिजियोलॉजिकल और एनाटॉमिकल डेड स्पेस में. वहाँ पे क्या है? वेंटिलेशन इज देयर बट देयर इज नो परफ्यूजन, इसलिए कोई गैसियस एक्सचेंज नहीं होगा. सेम थिंग डायग्राम में देखेंगे. This is the alveoli जहाँ पे ventilation is there but there is no perfusion. Since there is no perfusion तो हमारा जो इंस्पायर्ड एयर में जो ऑक्सीजन कंटेंट होगा या कार्बन डाइऑक्साइड कंटेंट होगा that is also in our alveoli. Is this point clear with everybody? तो इंस्पायर्ड एयर में ऑक्सीजन का पार्शियल प्रेशर कितना होता है? 149 और 150 mmHg. Partial pressure of carbon dioxide in inspired air is 0. So we can say this one that partial pressure of oxygen at the level of alveoli in this situation is equal to partial pressure of oxygen in the inspired air, that is 149 mmHg. We can say this one also. Partial pressure of carbon dioxide at alveolus level is equal to partial pressure of carbon dioxide in the inspired air in this situation. Inspired air में we all know carbon dioxide is nil, so it is 0 mmHg. ठीक है? Ventilation perfusion infinite होगा तो partial pressure of oxygen and carbon dioxide. Is this clear? Everybody. Moving to the next, that is the ventilation perfusion ratio is 0. कब 0 होगा? जब हमारा ventilation is not there but there is a perfusion. ठीक है? तो यहाँ पे क्या होगा? हमारा perfusion waste होगा, shunted होगा. तो यहाँ पे जो partial pressure of oxygen at the level of alveoli होगा that is same to the partial pressure of oxygen in the deoxygenated blood. Is this clear? So deoxygenated blood में partial pressure of oxygen is 40 mmHg. ठीक है? Partial pressure of carbon dioxide at the level of alveolus out here is equal to partial pressure of carbon dioxide in the deoxygenated blood. And deoxygenated blood में carbon dioxide का partial pressure होता है 45 mmHg. So this is the partial pressure of oxygen and carbon dioxide in the situation of ventilation perfusion ratio 0. Next and the last situation, that is ventilation perfusion ratio is normal. That is 0.8. Yani ventilation is also there, perfusion is also there. Sorry, perfusion is also there. So there is gaseous exchange. And gaseous exchange की वजह से हमारा पार्शियल प्रेशर ऑफ ऑक्सीजन एंड कार्बन डाइऑक्साइड चेंज होगा. तो पार्शियल प्रेशर ऑफ ऑक्सीजन एंड alveolar level is 100 mmHg. Partial pressure of carbon dioxide at the level of alveolus is 40 mmHg in this situation. ठीक है? Is this clear? अब इसी को हम तीनों पॉइंट को मिला के ग्राफ प्लॉट करते हैं, दैट इज नोन एज ऑक्सीजन एंड कार्बन डाइऑक्साइड डायग्राम और वेंटिलेशन परफ्यूजन डायग्राम. ठीक है? फर्स्ट पॉइंट इज दिस वेंटिलेशन परफ्यूजन रेशियो इज इनफाइनाइट. जहाँ पे वेंटिलेशन वाज देयर बट देयर वाज नो परफ्यूजन. तो पार्शियल प्रेशर ऑफ ऑक्सीजन एट द लेवल ऑफ alveoli इज सेम टू द इंस्पायर्ड एयर. ठीक है? इंस्पायर्ड एयर में ऑक्सीजन कंटेंट इज 149 mmHg. Partial pressure of carbon dioxide in inspired air is 0 mm of He. तो पॉइंट कहाँ जाएगा हमारा, बिकॉज हमने एक्स एक्सिस पे तो ऑक्सीजन का पार्शियल प्रेशर लिया, वाई एक्सिस पे कार्बन डाइऑक्साइड का लिया, तो कार्बन डाइऑक्साइड का प्रेशर सिचुएशन पे 0. नेक्स्ट इज वेंटिलेशन परफ्यूजन रेशियो 0, जहाँ पे वेंटिलेशन इज नॉट देयर बट देयर इज अ परफ्यूजन, तो सिचुएशन में पार्शियल प्रेशर ऑफ ऑक्सीजन एट द लेवल ऑफ एल्वेलस इज 40, पार्शियल प्रेशर ऑफ कार्बन डाइऑक्साइड एट द लेवल इज 45. तो ये पॉइंट आ गया हमारा. वेंटिलेशन परफ्यूजन नॉर्मल दैट इज 0.8, उस सिचुएशन में पार्शियल प्रेशर ऑफ ऑक्सीजन कितना होता है 104 mm of He एंड पार्शियल प्रेशर ऑफ कार्बन डाइऑक्साइड कितना होता है 40 mm of He. तो ये थर्ड पॉइंट आ गया. इन 3 पॉइंट्स को व्हेन वी जॉइन वी गेट दिस ऑक्सीजन कार्बन डाइऑक्साइड. ठीक है, समझ में आया सभी को? एवरीबॉडी इज दिस क्लियर? अभी तक सेशन में किसी को कोई डाउट है तो क्लियर कर सकते हैं, क्योंकि नेक्स्ट अब हम क्वेश्चन पार्ट स्टार्ट करेंगे. एवरीबॉडी इज दिस क्लियर? डू रिप्लाई फास्ट. चलो फिर क्वेश्चन पार्ट स्टार्ट करते हैं. फर्स्ट क्वेश्चन ऑफ टुडेज सेक्शन, transport of carbon monoxide is diffusion limited. Why is it so? High affinity of carbon monoxide for hemoglobin. Alveolar membrane is less permeable to carbon monoxide. Carbon monoxide crosses epithelial barriers slowly. On exposure to air, there is a sudden increase in partial pressure. So everybody answer this question. ट्रांसपोर्ट ऑफ कार्बन मोनोऑक्साइड इज डिफ्यूजन लिमिटेड. डिफ्यूजन कब होता है? जब हमारा गैस हमारा प्लाज्मा में डिसॉल्व हो, देन ओनली डिफ्यूजन अकर, क्योंकि उसी की वजह से कंसंट्रेशन ग्रेडियंट आएगा, पार्शियल प्रेशर होगा. बट कार्बन मोनोऑक्साइड की एफिनिटी टुवर्ड्स हीमोग्लोबिन इज 210 टाइम्स मोर. So all the carbon monoxide bind with the hemoglobin, no binding with the plasma. So that's why it is diffusion limited. Answer is A. Clear everyone? Moving further to the next question, carbon dioxide is primarily transported in arterial blood as dissolved from carbonic acid, carbamino hemoglobin bicarbonate. As it is primarily transported in the form of bicarbonate, 70% in the form of bicarbonate. Coming to the next one, carbon dioxide diffuses more easily through the respiratory membrane as compared to oxygen. Why is it so? It is less dense, more soluble in plasma, less molecular weight, less partial pressure of carbon dioxide in the alveoli. Carbon dioxide diffuses more easily through the respiratory membrane. Why is it so? Because it is 20 times more soluble in plasma. Answer is B. Coming to the next question. In mouth-to-mouth respiration, we provide an oxygen concentration of, we are providing the 16% oxygen. Our expired air consists of 16% of oxygen. So answer is 16%. Is this clear with everybody? Moving to the next question. Fraction of inspired air in the mouth-to-mouth respiration is 0.16, 0.19, 0.21 or 0.26. It is 0.16, very true. Coming to the next one. Arterial carbon dioxide level is, carbon dioxide pressure, partial pressure of carbon dioxide in arterial blood is 40 mm of He, 37 mm of He, 45 mm of He, 60 mm of He or 42 mm of He. Partial pressure of carbon dioxide in artery is 40 mm of Hg. Answer is A. Coming to the next one. Oxygen, which is about 21% of inspired air, exert a partial pressure of 160, 240, 580 or 760 mm of Hg. Oxygen, which is 21% of inspired air, exert a partial pressure of, it exert a partial pressure of 160 mm of Hg, क्योंकि हमारा जो barometric pressure है 760, इसका 21% is 160. Coming to the next one. One intern calculated the concentration of oxygen in the blood is 0.002 ml per ml of blood. Considering the atmospheric pressure of 760 mm of Hg, how much appropriate approximate oxygen tension could have been in the blood. ठीक है, we have to calculate oxygen tension. फॉर्मूला क्या होता है? डिसॉल्व ऑक्सीजन कंटेंट इज इक्वल टू पार्शियल प्रेशर ऑफ ऑक्सीजन इनटू सॉल्युबिलिटी कोएफिशिएंट ऑफ ऑक्सीजन. So this is the formula. Do remember everybody? Oxygen concentration is equal to partial pressure of oxygen into solubility coefficient. And we all know solubility coefficient, normal solubility coefficient of oxygen is 0.003 ml per 100 ml per mm of Hg. 0.003 ml per 100 ml per mm of Hg. So this is the normal solubility coefficient. तो इससे हम ऑक्सीजन कंटेंट निकाल सकते हैं, डिसॉल्व ऑक्सीजन कंटेंट. इज दिस क्लियर विद एवरीबॉडी? ऑक्सीजन कंटेंट हमारा गिवन है, दैट इज 0.00225 ml per ml of blood. पार्शियल प्रेशर निकालना है, सॉल्युबिलिटी कोएफिशिएंट इज गिवन, सो फॉर्मूला से हो जाएगा एवरीबॉडी. इज दिस क्लियर? चलो, मूविंग टू द नेक्स्ट क्वेश्चन. Which of the following statement is or are true about the ODC curve? Fetal hemoglobin shift the curves toward left. Hypothermia shift the curve towards left. Hypercarbia shift the curve towards right. Left shift causes more release to the tissue. OHDC के लिए fetal hemoglobin में हमारा ODC curve shift towards left. Hypothermia में OHDC curve shift towards left. So answer is both A and B. Is this clear? Coming to the next one, oxygen delivery to the tissue is decreased by decreased hemoglobin level, decreased partial pressure of oxygen, increased partial pressure of carbon dioxide, increased bicarbonate or increased pH. Oxygen delivery, obviously hemoglobin कम होगा तो oxygen delivery to the tissue decrease होगा. Increased pH में हमारा OHDC curve shift toward left, so there will be less delivery of oxygen to the tissue. So answer is both A and E. Is this clear with everybody? Do reply fast. Is this clear? Moving to the next question. Fetal hemoglobin has higher affinity of oxygen due to decreased 2,3-diphosphoglycerate concentration, reduced pH, increased release of carbon dioxide, OHDC shifted towards right. Fetal hemoglobin has higher affinity for oxygen because of its decreased 2,3-diphosphoglycerate concentration. Coming to the next, an increase in which of the following parameter will shift the ODC curve towards left? Increased temperature, increased partial pressure of carbon dioxide, increased 2,3-diphosphoglycerate, increased oxygen affinity for the hemoglobin. OHDC curve left shift कब होगा? It occurs when there is an increased oxygen affinity of hemoglobin. Then only this ODC curve shift towards left. So answer is D only. Coming to the next one, oxygen affinity is increased by all of the following except alkalosis, hypoxia, increased fetal hemoglobin or hypothermia. All of the following except oxygen affinity is increased by all of the following except हमारा alkalosis situation में oxygen affinity is decrease, alkalosis situation में oxygen affinity increase होता है, fetal hemoglobin में oxygen affinity increase होता है, hypothermia में oxygen affinity increases, hypoxia में oxygen affinity decreases, so there is a release of oxygen. So answer is B only. Coming to the next one, factor responsible for the left shift of ODC curve is increase in 2,3-diphosphoglycerate, fall in temperature, fall in pH, increased level of carbon dioxide in the blood. Left shift of ODC curve कब होता है? Fall in temperature causes this left shift of OHDC. Coming to the next, all of the following factor influence hemoglobin dissociation curve except chloride ion concentration, carbon dioxide tension, temperature or 2,3-diphosphoglycerate level. No, the chloride ion concentration doesn't affect our OHDC. Answer is A only. Coming to the next one, OHDC is shifted towards right in all except hypercapnia, rise in temperature, raised 2,3-diphosphoglycerate level, or metabolic alkalosis. OHDC curve shifted towards right in all except OHDC curve alkalosis में हमारा left shift होता है, not right shift. The answer is D only. Is this clear? That's all for today's session. Hope you all like the session. If you like the session, do like and share and subscribe our channel, that is Unacademy Live NEET PG. So subscribe our channel and press the bell icon so that you will get notification of every class and you won't miss a single class. So do subscribe our channel and do share the classes, everybody. So that's all for today's session. Hope you all like the session. So let's crack it together. See you all in the next session. This is the code Dr. Nidhi. If you want to join any paid course, you can use this referral code to get additional 10% off. For today, the offer is, if you use this code, you will get additional 20% off. So do enroll yourself, because this is the best time to enroll yourself, because the fees are very, very economical this time. So thank you so much for joining. See you all in the next session. Bye-bye, everyone.